So yes, good morning and welcome. This is the second showcase event that we are holding this week on behalf of the East Genomic Medicine Service, the East GMSA. My name is Professor Dick Sandford. I'm Clinical Director of part of the East GMSA, the East Genomic Medicine Service Alliance. Next slide, please. And so what I would like to do now is just to proceed into just a very brief introduction of the East Genomic Medicine Service. I'm sure that some of you will be very well aware of who we are and what we do, and may even have ordered genomic tests in your own clinical practice yourself. But from a similar set of questions we used in the showcase that we held on Monday to discuss cancer genomics, I think we were aware that a significant proportion of people on the showcase then were really starting to explore the relevance of genomics to their practice for the first time and didn't have that detailed experience of accessing genomics. So we're really coming to find out a lot of information, perhaps not for the first time, but obviously to sort of build up their knowledge and experience. So just to really sort of put a little bit of context around this, the East Genomic Medicine Service Alliance, the GMSA, together with the East Genomic Laboratory Hub, the GLH, form NHS East Genomics. We're one of 7 genomic medicine services that were initially founded in about 2018. And we have a number of core missions and aims, and all of those collectively are to embed genomics within the NHS. But firstly, we are working to ensure that there is equal access for eligible patients to nationally commissioned genomic tests. And those tests are set out within a document called the National Genomic Test Directory. And that means that no matter where people live or which hospital they are treated at, they should have access to genomic tests where relevant. In addition to that, we support the establishment of testing pathways for cancers and rare disease. We'll be focusing on rare disease today, and that's existing established pathways, but also looking for the opportunities to improve and develop new pathways. And of course, our aim is to assist all clinicians within the NHS to request genomic tests. And finally, obviously, one of our main aims is to introduce new models of care that perhaps support earlier access to genomic testing and therefore result in high quality, more personalised treatments and screening for patients being seen within the NHS. The East clearly describes a large geography. This is you can see on the map here that this is what we would typically call the East of England and the East Midlands. The overall population is about 11 million, and it covers 29 NHS trusts. These are acute trusts, mental health trusts, and community trusts, plus a lot of other organisations delivering healthcare within the NHS, including primary care, and in addition to that, 11 integrated care boards. So this is obviously a complex geography, and the testing that I've described being available through the National Genomic Test Directory is delivered by 3 laboratories: the central hub, which is in Cambridge, and 2 additional laboratories in Leicester and Nottingham. And all genomic activity in this area will go through those 3 separate, but obviously working in a fully integrated manner together. And I just wanted to show you a little bit of a structure of the Genomic Medicine Service. This perhaps gives you a little bit of an idea about what the East Genomic Medicine Service looks like. So I've already discussed a little bit about the delivery of genomic testing. That is done through the genomic laboratory hubs and other laboratories. A network called the Networks of Excellence, which I will come to, and a series of transformation projects that we've previously carried out, and some of those transformation projects will be described in this showcase. All of that activity is delivered through a series of working groups, and obviously the medical and rare disease working group is the one that we're focusing on today, but there are other working groups covering nursing and midwifery, pharmacy, research and innovation, cancer, informatics and digital, and comms, for example, and they all report into a series of management boards and an executive board which covers the entire East Genomic Medicine Service, and that is chaired by a trust chief executive, and ultimately that reports into NHS England. And in addition to that, well, that will also involve our strategic partners, for example, industry, academia, cancer alliances, primary care, and other organisations as well. So there's a very large infrastructure that supports the genomic medicine service. And I also wanted to highlight a very critical part of how the East Genomic Medicine Service works, and that's through our patient and public voice panel. You'll be hearing from members of this panel during today's showcase, and that's chaired by Chris Hind, and vice chair is Eddie Blair, and they are representatives from across the east of England and the East Midlands region, and they bring a range of experiences of genetic conditions and genetic testing and their own established networks. So we really look forward to hearing from them, and just to also make everybody aware that much of our activity is both delivered and co-designed with members of the PPV panel. And I briefly mentioned the new genomic networks of excellence. They have broadly started this year and will be running for a 2-year period, and they've replaced some of the specific projects that we've been doing in this region that I've said that we will discuss shortly. And these new genomic networks of excellence are looking for ways of rapidly transitioning from research into clinical practice, and they cover areas such as prenatal medicine, which we will be dealing with in our next showcase, various cancer themes, including circulating tumour biomarkers, hemato-oncology, but also rare inherited disease that we'll be hearing from today, cardiovascular disease, artificial intelligence, pharmacogenomics, and also the genomics of infectious disease, so pathogen sequencing, for example. So those are exciting new developments in the areas of genomics that will be coming to all regions of NHS England over the next year or two. And I've highlighted some of our strategic partners, but I just wanted to make you aware that really the genomics ecosystem in the east of England and East Midlands incorporates a very, very wide range of organisations. So I've put some of them up on this slide here, and there are probably many more as well. If you represent an organisation and you feel that you would like to contact the East GMS, or feel that you've potentially got a role in delivering genomic medicine, please get in touch with us after this showcase or at any time afterwards, and we would be delighted to hear from you. And also I just wanted to point out all of our resources and contact information is available at the East Genomics website, and you can see the address there, and there's a lot of information that you can use to develop your own clinical practice, including training and education. And you can also sign up to receive our newsletters and updates there as well. So I would strongly recommend that when you have time, you initially start off just browsing through the various parts of the website. And the final slide. You've all been sent the showcase agenda for today. I'll just leave that on screen just to highlight that we have one more showcase tomorrow in prenatal and paediatric medicine. But once again, thank you very much indeed for joining the showcase today.
Morning, everyone. Welcome. My name is Emmanuel Lua. I'm the Strategy Director for East GMSA, and I'll be introducing the speakers today, but also facilitating the Q&A session at the end, as Dick outlined. So pleased to introduce our first speaker of the day, Prof Guru Aithal, who's our medical lead at East GMSA, and his presentation is How is Genomics Impacting Rare and Inherited Conditions? Welcome, Guru.
Thank you very much. I'll present a series of patients and family I have come across from the period where research was driving this area, and then gradually how genomic medicine as well as the alliance has impacted these patients and families. And I'll add some numeric data in between just to give you much more objective status of play or service, and look forward to how we are going to make it better. Thank you. This starts with two sisters. They belong to 4-generation family, and I came across them now over 15 years ago. The family had moved from India 4 generations ago to Kenya, and 1970s they came as a family to UK, and they're now widely spread in UK. It starts with 2 members of the family who observed changes in the health of their family members and then drove what I'll present is the journey of the family through genomic medicine. I wouldn't really mention individuals or mark them in the family, but I have been involved with them for last 10 years or so. So they are very much permitted me to present all this information formally. The first brother developed cirrhosis, and then when the second person developed hepatocellular carcinoma, which occurs 80% of the time in people with cirrhosis, the alarm bells started ringing. And these were the questions which the family members had. And next, and these were the answers they got. So as usual, initially the questions arise, and when you have a condition which is undescribed, that is what the response from the specialty you get or medical specialty you get, because by inherently all we are talking about are rare diseases, and we are taught in medicine that common things are common, so people rarely consider rare diseases. So the third person in the family was diagnosed with cirrhosis, and one of the family members during the treatment of hepatocellular carcinoma had a complication, which was a major surgery, and then died of bleeding. Then the coroner's investigation, one of the sisters took a courage to write a letter to the coroner saying, well, can you ask the panel, is there an underlying genetic cause for it? And then patient was first time referred to a gastroenterologist who just thought that it was a bit surprising because the conditions they had, like cirrhosis, we have got about anywhere between 10 to 15,000 people in the country with that diagnosis, and about 2 out of 1,000 people get diagnosed every year with cirrhosis. So it's not uncommon, but to have 2 family members was a little bit uncommon because there were no risk factors for cirrhosis. So patient was referred to a clinical genetics first time about a year after the initial questions started arising. And I got involved as clinical genetics department felt that I had expertise in this condition, and this wasn't really fitting with anything that was described in the literature. So we did exome sequencing. On the right-hand side, you can see, I don't think my PowerPoint will work as an arrow, but you can see on the top, one spelling mistake or spelling change in the code of the gene, and below there is one change in the what we call an amino acid, a block, which decides what the function of the protein will be, was different. And sequencing was done in about 24 members of the family. And that results in the bottom left corner picture. Fat gets into the liver through different means. Usually, much of it is packaged, tying it up with the protein called ApoB100, and a transporter or a carriage, which is called microsomal triglyceride transfer protein, with another protein together, work together to package it and get it out of the liver. So this wasn't happening. So lots of fat was being built that would generate inflammation, that would generate scarring, causing cirrhosis, that led to liver failure or a cancer. So this took about 3 years for us to conclude just the genetic diagnosis, another 4 years, including 2 years of COVID-19 to do more research on, to confirm the mechanism by which this genetic alteration would lead on to the condition, and then answer many of the questions which family had. And this is how the system worked at the time. just about 100K project was starting, and 100K project took people who were clear-cut family history, but where the diagnosis hadn't been done and were not part of research. So we didn't really get the luxury of getting into 100K project, but we got the results nevertheless, probably ahead of 100K project completed. And on the left-hand side, how the service is or how the system is in US. I deliberately put it out just to show that this problem is really universal. If you take US, there is still not anything like GMSA there, but they have got an undiagnosed disease network. They still offer a service in a research-like way. 40% of people who are referred there are accepted for the program, and they come to a diagnosis. This is in that table here. 35% will get eventually a diagnosis. So this is more realistic picture. The right-hand side, you have got data from rare experience based on the survey. I'll just stick to the left-hand side. If you have got a diagnosis, then it changes treatment in 21% of people. Way of testing changes more than 1/3, counseling more than 1/3, and about 1/3 of the time, just like in our family, we come about identifying a new condition which wasn't described till then. If you go by the right-hand side, this is a survey done a few years ago. 890 people responded, but these are the people who already had some conditions, so they are further downstream compared to the left-hand side. And you can see that most of them, right pie diagram, had either misdiagnosed or had more than 2-3 times had change in diagnosis made before the final confirmation is done. And then a bottom picture shows how long they had to wait to really come to that conclusion. Some of them over 20 years, but most of them 2 or 5 years, just like our family had to go through. And then this is another family, and I only got to know that they were part of the family when the second person arrived in my service with ascites. Ascites is fluid buildup in your tummy, which suggests that liver is failing. And the person had some drinking history, but had stopped drinking for 2 years. It's not uncommon for people to, again, have liver disease progressing even after drinking if you stop drinking too late. But the crux is that one of my juniors cared to ask family history, and he said his brother was also my patient, and we were treating that person to what we call a non-cirrhotic portal hypertension. And so we did an investigation. He had very high pressure in the liver, which is measured as hepatic venous pressure gradient. He had scarring in the liver amounting to cirrhosis. And I've put in a slide of this biopsy. And if you have a zoom in, I'm not asking to zoom now, but there are some number of red dots, which are not really simple part of cirrhosis, which suggests that he has got probably a risk factor in addition to alcohol, what's called an alpha-1 antitrypsin, which is deficient. But this genotype does not present with severe liver disease. So we thought this is more than that. And with a family history, we refer to clinical genetics. Now, this one, there was a clinical genetics test. Clinical genetics sent him to look for telomeropathy. Just briefly about telomere, I've got a picture of a gene which looks like an X in the picture, and the pink bit is a cap called telomere. This cap protects the DNA material wearing off, but it also has got a half-life, so it gently, we lose about 20-30 base pairs per year as we get older. So this is one of the part of the DNA or chromosome which determines the organ aging. And so there is a system in the body which makes up the worn-off cap or stitches it together, creates a bit more thickness to it. And there are 2 different genes. One of them is a protein called telomerase reverse transcriptase. Another one is telomerase RNA component. So if one of them have got a spelling mistake in the coding, then this cap doesn't really get refurbished, and you lose the cap and the organs age. And this patient family had a predilection to a lung fibrosis. We were working up this person for a liver transplantation. We needed to really consider whether he needed lung and liver transplantation together. And we found out that he had a lung problem only after testing, after the genetic results came along. So treatment plan and natural history of a condition can be impacted by the diagnosis. And this was all the time when we were developing and contributing to 100K Genome Project. And this is the annual report of our Chief Medical Officer at the time, Sally Davis, who produced a document called Generation Genome. And this had ingrained several components of genomic medicine into development of services. And this is an important document. And 2018 onwards, as you heard from Dick, that we have been starting to develop the service element of genomic medicine. And this person presented when such a system started coming up. And we had a patient who was being referred to liver transplantation after presenting to our own service with itching. He had developed jaundice and itching fairly recently, and itching was stopping him in eating and drinking. And you can see his body mass index is 18.3, his skin and bone. He had all the tests done which were negative, and he had a biopsy which just shows that there is some stasis of bile within the liver, nothing more, nothing diagnostic. But we had a directory which had a R171 cholestasis panel. So we sent a blood test, and about 6 months later, we got the diagnosis, which is a transporter within the liver, which takes bile from within the cell of the liver into the bile duct, which is the pipeline, was really not working very well. It's a well-described condition, but very rarely presents in adulthood. If it was a child, he would have probably had diagnosis, but he was presenting as an adult, which is progressive familial intrahepatic cholestasis. He then went on to have a series of treatments for itching. None of them really helped. So he was listed for liver transplantation. Yeah. And this is just a brief summary. It's a rare condition, common in even these rare patients are all in a pediatric age group. I've got about 3-4 families who are developed either from pediatric to the adulthood or newly diagnosed from the adulthood. 2022, a medication came. This is almost one of that kind, which specifically targets transporters in the ileum and hence really remedies the problem with the working of the bile transporter in the liver and overall reducing itching. And this was licensed for the genetically diagnosed progressive cholestasis syndrome. And so we were able to prescribe him, and his life has changed and is now off the list of liver transplantation. This is just to say that how treatment guided based on genetic testing and positive results will have an impact on patient care. And this is what we need to do to improve. You've got a survey in my own specialty, which was done for the trainees. And this is how the trainees feel. On the left-hand side, they just show that how well prepared they are. Hardly anybody is very well prepared. Only 8 to 15% think that they are well prepared, and rest of them either poorly prepared or are very poorly prepared. So we need to have education of even the workforce who are delivering this genomic medicine service, and we are far from ready for it. The right-hand side, what are they looking for? They're looking for training of different elements of genomic medicine, and then hopefully we can boost this up fairly rapidly and maintain a cycle of it so that starting from the current set of doctors to the future doctors. We can train them into genomic medicine coming into clinical practice. And this is just coming to this evening. Most of you are hoping to watch semifinals, and timing it right, British Heart Foundation have put up murals in 12 towns where representing 12 people every week we lose for sudden cardiac death. This is one from Nottingham, which is on Josh Downey, and this is his family. Two of their sisters are Olympic gymnasts. Josh was a football fan, but he was playing cricket in Liverpool when he had a sudden cardiac death. Postmortem revealed that he had inherited arrhythmogenic cardiomyopathy. Just finally summarizing what will happen now on sudden cardiac death. You have got a full talk. Next slide, please. Full talk on sudden cardiac death. This is a rare condition defined as when someone passes away unexpectedly, and when you investigate him thoroughly, including a post-mortem examination, you find there is some structural condition in the heart, then it's called sudden cardiac death. The aim is to identify family members who are at risk and consult them, and then implement any preventative measures one can have to reduce the risk of that. So way of identifying should happen at the time of autopsy, and identifying people to have autopsy when there is a potential chance of finding sudden cardiac death. And we will be implementing this across all the trusts, which are beyond the 4 primary trusts involved in Genomic Medical Service Alliance. So that's where I'll stop. Thank you very much for listening. I need to thank family members and research volunteers who has helped us in research, as well as permitting me to present their information, and the gastrointestinal liver disorder team of NHS Nottingham Biomedical Research Centre, who is behind some of the research that I presented here. Thank you.
Great. Thank you, Guru. Just a reminder, we'll take questions at the end of the session, but in the interim, just please put in any questions that you may have into the chat. Our next talk is delivered by Dr. Javier Gomez, consultant in clinical biochemistry at Norfolk and Norwich University Hospitals. He'll be talking about finding the missing 95% familial hypercholesterolaemia in Norfolk and Waveney. Welcome, Dr. Gomez.
Thank you very much. We can show the first slide. That's excellent, thank you. So I'm going to talk a few minutes about familial hypercholesterolemia, and then I will pass to my colleague, Shelina Rajan, specialist in nurse in familial hypercholesterolemia. We are talking today about rare diseases, but familial hypercholesterolemia is actually an also rare disease, and I'm going to explain why. So the prevalence, in the past, the prevalence was supposed to be 1 in 500, but with the availability of genetics, which is proving to be hugely beneficial for patients and for the NHS, we are seeing that the incidence, the prevalence of this disease is not 1 in 500, but there are reports up to 1 in 80 patients. Generally, we assume that is something around 1 in 200 as a minimum. So the minimum is 1 in 200. And that means a huge number of patients in the UK and also in Norfolk. So in our region, for example, we cover a population of 1,100,000 or 200,000. And that means that we have at least 4,400 patients or 4,500 patients, of which, unfortunately, only a very small number have been detected. But the real question is, and why FH matters? So why is it important? Well, it is important because if we look at people with no FH, the chances for any of us to have a heart attack in our lifetime is quite small. It's quite small. However, if we have this condition, the chances of having a heart attack is huge. As you can see here, 80%, there are different reports, but the most frequently reported is 85% of men and half of women are likely to suffer one of these episodes by the age of 65 years. And historically, is at least half of the men by 50 years of age, 30% of women by 60 years of age. What do we see in real life, in the clinical real setting? Well, we see that these conditions, the onset of heart disease is happening sooner and sooner in patients. And this is a combination of lifestyle factors and diet and risk factors and all these factors that are influencing in cardiovascular outcomes in the UK and in the world. But the typical presentation is a patient, used more frequently a man, but can be a woman as well, that in their 40s, even earlier, in the early 50s, they come to the emergency department with a heart attack. And then all the battery of investigations have to follow. What is the situation in the world about this? Well, it's not very bright, I have to say. There is only one exception, and it's the Netherlands, because the Netherlands has been working on this since the 80s. They had an FH program since that early stage, and quite a few number of epidemiological studies with big numbers of many thousands come from the Netherlands and been very, very helpful in planning and making national plans in other countries. And we can see the UK in that graph. We are not very well positioned. And this data is based, this is a bit old graph, and that was based when the prevalence was supposed to be 1 in 500, which is not the case anymore. So what is the situation now in the UK, particularly here in our country? Well, the fact is that the cost of cardiovascular disease is huge. And you can see, the number of initiatives, NHS and NHS England initiatives try to address this high cost by implementing preventive measures. Also, unfortunately, in our region, in Norfolk, if we compare our performance in cardiovascular outcomes with other regions, we are not doing very well in that regard. So it's something that has become quite relevant in the last few years. Another important factor is that luckily, patients are becoming more and more aware of this condition. I regularly, I would say, receive either emails or letters or something from patients that I don't know of, the patients in the community or somewhere else. Sometimes there are people, staff working in the hospital, and they drop an email to me and say, I read this in the news, I've seen this in the magazine, I read about this, I look at this in the internet, and I think I might have familial hypercholesterolemia. What do I do? Patients are becoming more aware of this condition, and that's very, very important. And also, we have to give thank you to organizations like Heart UK. They are doing brilliant work in relation to this, and other organizations in promoting this disease and trying to help to address this important problem. You will have seen that there is several editions already of the Atlas of Variation in Diagnostic Services in the UK, and this is connected to the difference in services provided and outcomes, and also some areas are disadvantaged in relation to familial hypercholesterolemia, and they are clearly disadvantaged. And it's for this reason that our ICB, the Norfolk and Waveney ICB, set a priority for our region to tackle inequalities of outcomes, which is excellent as a priority for the ICB. And this is clearly one of the areas where we are not doing as well as we should. The NHS long-term plan has been published, and they made a specific emphasis on FH. Thank you very much, to East Genomics and all the team and everyone involved in genetics, because they are doing fantastic work and is helping a lot to address, to focus on FH and to identify these patients. And there are nice guidelines and also quote targets for primary care. I want to show you this slide because this is from last year, in 2022, and it's the number of referrals to the service I lead for lipids. And you can see from February, January, February, March, April, May, June, etc. It was quite steady, and all of a sudden in September, from September onwards, there was the number of referrals multiplied by 2, by 3. This was a consequence of the implementation of the quote targets for GPs. The quote targets are the targets set up by the government, essentially, for primary care to meet in relation to specific things. Could be hypertension or could be whatever. And they set a target specific for familial hypercholesterolemia. No one was prepared for that. Primary care was not ready. The secondary care services were not ready for the huge number of patients that were. So it had to be withdrawn. But the positive thing is that GPs, primary care, many colleagues became aware that this is an important problem in healthcare. And why is it an important problem? Well, you can see the figure. As I said at the beginning, we cover a bit more than 1 million people in our region. And that means we have about, theoretically, 4,500 patients, of which about 300 only have been identified. So that's the title of this presentation, the missing 95 or 98%. There is a lot of patients missing. What are the keys then for successfully address this problem? Well, we cannot do this on our own. We cannot do this just with a doctor, a nurse sitting wherever. We need the collaboration with a number of people. It's a teamwork, really, that can make a change. And I put some here, the initial ones, obviously. So East and GMSA have been critical in implementing a pilot project, but the Genomics Hub, obviously, our ICB, GPs, not just ICB, but GPs, individual GPs addressing and helping on this, and secondary care, and so on, and patients as well. So it's critical that all this work is combined in a joint effort. And I would like to pass now to my colleague, Shelina Rajan, because she's going to explain you this particular project and the results we got so far.
Thanks, Javier. Good morning, everybody. My name's Shelina, and I'm based out at the Norfolk and Norwich Hospital in Norfolk. So I just wanted to focus the remaining slides this morning for our talk on what's going on within the Eastern region and more specifically locally in Norfolk. And so I'm going to start off by talking about the East Genomics Information Zone. So in order to facilitate healthcare professionals to be able to make patient referrals across the Eastern region, the FH Info Zone has been designed specifically for specifically primary care clinicians to help them engage with FH and also to raise awareness of what FH is. So a pathway has been put together. So within primary care, normally patients are referred using either what we call the Simon Broom or the FH Wales or the Dutch lipid criteria, which is a specific set of biochemistry markers which indicate whether or not a patient needs to be referred. So this pathway is really nice in terms of how it just shows the flow of when patients should be referred for genetic testing. And there's also a nice FAQ section as well, and this will help, as I say, inform clinicians as to just some specifics about FH and who it's intended for. And also clinicians can also download the FH test order form, and based in the Eastern region, our samples will be going over to the Cambridge GLH. Ian, if you wouldn't mind just popping the link for the information zone into the chat when you get a chance, that would be great. Thank you. Thank you. So focusing specifically on what's going on in Norfolk, thanking the East GMSA for their initial funding for this pilot project. My initial thoughts when I took up the post was that I would be embedded within GP sites across Norfolk, helping out with trying to identify patients who could be at risk of FH. But it became very clearly evident that that just wasn't going to be practical. So a more pragmatic approach was to develop a pilot hub, which is actually housed within the Norfolk and Norwich Hospital. So what we are doing is, thanks to Nottingham University, who devised the FAMCAT2 algorithm, it specifically looks at patients who can be at risk of FH. Now, FAMCAT2 is actually embedded within Eclipse, which is a NHS digitally assured platform that sits within primary care electronic patient records, so System 1 and Eclipse. And it will pull out patients who are at very high, medium or low risk of FH. And within that platform of Eclipse sits another piece of software called Pegasus. And that's a patient engagement platform that actually then contacts patients via text message. And patients can then go straight to a secure portal where they can read a little bit more information about what FH is. The Recite Me tool is also embedded within that platform, so that encourages equity of access for patients where English isn't their first language. They can then put themselves into a 45-minute appointment where I will conduct a telephone appointment, providing bespoke genetic counselling, recording family history of CVD, and taking verbal consent. I then provide all of the test order forms for the patient, send them by post, and the GP gets copied into the clinic letter so that they can apply the appropriate code, so there's no duplication of requesting of tests. And then sometime later, I'll get the results and have a second phone call and discuss what their specific result will mean to them. If they're already on lipid-lowering medication, then it's important for them to carry on for that medication, because that will be lifelong treatment. Because as we know, the presence of FH increases the likelihood of developing cardiovascular disease. So it's really important. And for those patients that aren't currently on lipid-lowering medication, that conversation becomes more of a priority in terms of directing the GP as part of the clinic letter to start the patient on the statin pathway. So as I say, the bottom of the slide just kind of just gives a summary of the actual pathway itself. And important also conversations that I have are around statin use, what the side effects can be and what that pathway will be, and reassuring patients, because unfortunately, as we know, statins can have a bit of a negative press, but there's also plenty of research to suggest that it's extremely effective and efficacious in terms of reducing LDL cholesterol by 50% as per the NICE guidelines. I talk to patients around maintaining healthy diet and lifestyle, etc. And a lot of patients do take me up on referral to dietitians as well. So that's really positive. Okay, so what have the what has the pilot shown so far? So we started off in June 2023, and Javier has already alluded to the multiple key stakeholder collaboration, particularly the Norfolk and Waveney ICB and primary care. So I've developed what I would like to call quite a pioneering model, really, that shows that we can identify very, very succinctly patients who are at risk of FH, and I've been focusing specifically on those patients who are at very high and high risk for the purposes of the pilot. So we have 105 GP practices across Norfolk, and 46 have so far engaged, and it has taken a lot of work to speak to practice managers to encourage engagement there. I feel like a salesperson at times, sort of convincing practice managers this is a really, really good service that they need to engage with, and all of the admin work is taken on by myself, which therefore reduces GP burden. So around about nearly 700 patients who were very high or high risk have so far been contacted, and we've had just around about a 20% uptake in terms of that translating to genetic test requests being sent to Cambridge GLH. And 88 patients, it's been recommended that they have their relatives have their cholesterol checked, because there's a high chance that they could also potentially have what we call a polygenic form of high cholesterol. But more importantly, is focusing on those 27 patients that will require cascade testing of relatives, because the inheritance pattern dictates that 50% of children of those index cases may potentially have picked up the condition as well. So if we didn't run this pilot project across Norfolk, 24 patients would not be on a statin now that would obviously need to have been on a statin. So this is really, really encouraging and positive. So as I say, the benefits of the service mean that we can identify and have an impact on the NHS long-term plan in terms of reducing that 92%. And it's proven to be a seamless pathway for referral for genetic testing. It's also assisting primary care to reach those IF and QOF targets that Javier was talking about, and it supports patients and GPs by making, as I say, those dietitian referrals as well. It's amazing the amount of information that's already out there, but when you actually pinpoint to patients about their diets, they're very keen to access this specific information. Okay, so just to talk about some of the challenges and summarise, we've already talked about the NHS long-term plan, finding the missing 92%, and of course everyone's reliant on funding for continuation of services. So we're waiting on tender books from the ICB as to what the fate of the service will be across Norfolk. So we also a challenge that I've also discovered is only 20% have taken up the engagement for or the invitation for the service. So we need to be more creative in terms of encouraging the easy to reach population, but also maintaining that equity of access for those hardest to reach populations. For example, those that have mental health problems or are digitally not as aware as some of the other population, so the digitally deprived. Really reliant on capacity at Cambridge GLH, but it's really important that the priority remains to maintain that patient identification by keeping the service going. And of course the take-home message really is that we can reduce cardiovascular disease by about 80%, and the model that we've got here in Norfolk, for every 5 samples that are sent, we are able to get one patient FH find versus 23 in the published literature, which is only available in 2022. So there's a massive striking difference there. And as I've mentioned, 24 patients who are now currently on medication. And I think the final take-home message is the alarming cost just to our trust ourselves that if we can identify around about the 4,000 patients that are across Norfolk, that's going to save the Norfolk and Norwich around about £7 million, which is absolutely staggering. So it's about what's happening in the future as well in terms of preventative care. And a final thank you slide.
Thank you, Shelina. Segues quite nicely in terms of the equity of access theme. Our next presenter is Dr. Kate Downs, lead scientist for rare and inherited disease at East Genomic Lab Hub, and her talk is on genomics for all, equity of access. Welcome, Kate.
Thanks very much. Hi, everybody. So my name's Kate Downs. I'm the lead scientist for rare and inherited disease at the East Genomic Laboratory Hub. So I thought I'd take us back, and I think Dick's already gone through these, but to really start to think about equity of access, we need to go back to the Genomics Service aims. And these are the aims that were set down in at the start, and this is really to provide consistent and equitable care for our communities, our country's population. And we're going to do that by having common national standards, by working to the test directory, and by allowing all patients an opportunity to participate in research and creating this national genomic knowledge base. So I think these are the principles behind how we want to deliver our genomic medicine service. And as we've introduced this over the last 5 years, I think hopefully we can really see that we are starting to deliver equity for our patients. Before 2020, maybe, there were pockets of excellence in different laboratories across the country. Different specialities and different disease areas were being focused on by different genetics labs. And so, it really was a postcode lottery of where you lived and which clinicians you were seeing, of whether or not you could access genetic testing for you or your child. So this National Genomic Medicine Service that we've developed over the last few years and are continuing to develop is really the linchpin of what equitable care for genomics is in this country. So we talked about already the regions that are associated with the Genomic Medicine Service. So we're in our East Genomics region, but we have 6 other genomic regions around the country, and we all work to these test directory and these standards that are set nationally. And so we have specialist testing, GLHs, we have national working groups where we get together and discuss these specifications and ensure that we're all delivering to the same standards. We've got standardized protocols that we share across the country. And of course, data sharing agreements are really important. So I've just tried to list out here a few things that are also going on behind that delivery component around how we're also trying to deliver this equitable service for all our patients. So there's a few bits and bobs there thinking about transformation and innovation of the future, trying to do this in a really a national way to make sure that all patients in the future will have access to this innovation. So we have national GMS transformation projects, and you've just heard about the FH transformation project. Moving forward, we've got the Genomic Medicine Service Networks of Excellence, which will do a similar job, looking for opportunities for transformation and innovation and bringing those into our national services. And you know that I keep on saying national, and this is really important. This is the equity piece. This is how we deliver innovation nationally to our patients. We also have a test evaluation working group, for example, where anybody, patient groups, clinicians, professional societies can suggest new tests to go on the test directory or amendments to the test directory. And so this is done nationally. We've got a national whole genome sequencing service, which is what I'm really going to focus on today, and our mainstreaming efforts. Of course, we can't deliver genomic testing through just our clinical genetics department. So mainstreaming is a big factor in how we deliver this equity of care. So as I've said, I'm going to focus on these 2 aspects today. I might be able to pop a few bits and bobs in at the end. So our whole genome sequencing service was introduced in December 2020. All the GLHs were asked to ensure that 1 patient and 1 family were submitted by the end of 2020, and I think we all reached that aim. At the time, there were 21 clinical indications that were delivered by whole genome sequencing, and WGS was performed centrally at Illumina. You can see on the schema in the right. DNA was processed at GEL, and then the analysis and reporting of the data was performed by the GLHs. So really importantly, you can also see on the right in the Genomics England section where the analysis of the raw data happens, there's also an option for patients who have consented for their data to be deposited in the National Genomics Research Library, that green blob. And what that does is it allows researchers to be able to access that data to perform cohort studies on rare conditions, but also for lots of other reasons too. And that data often feeds back into new diagnoses for our patients. So I've managed to get hold of some data around how many patients that we've been submitting to the whole genome sequencing service over the last 4 years. And so I'm going to share a little breakdown of some of this data today. And so first of all, just the number of families that we've been submitting for WGS testing. So our first case, as I said, was submitted in 2020. But since then, we've submitted 5,000 families from the East GLH. And you can see that we've got this increase of the number of families being submitted since the start of 2021. There are only certain clinical indications that you can use to order a WGS test if you're a clinician or a healthcare professional. And so so in 2020, as I said, we had 21 clinical indications, and now in 2024 there's 32. And you can see on the right, this is the number of probands, number of families that we've sent for testing. The majority of people that we've sent for testing are within the paediatric clinical indications and the neurology and neuromuscular clinical indications. And these are generally the really large gene panels where these conditions are really heterogeneous, and there's numerous genes that can be responsible for these conditions. So I thought then I'd have a look at this equity of testing piece. And firstly, I thought I'd look at the trusts where we have clinical genetics departments, because of course, the clinical genetics departments are probably responsible for sending a large proportion of families for testing for the whole genome sequencing. So I wasn't able to split up the clinical genetics departments from everybody else in these hospitals, but I hope that this will give you a flavour of this data. So we've got 3 trusts within our region with clinical genetics departments: the Cambridge University Hospitals, Nottingham and Leicester. And the total number of WGS testing that we're sending from these 3 centres accounts for about 75%, so as expected. But if we flick through these next few slides, we've got 2021 data, 22 data, and then 23 data. You can see that we've had an increase in the number of patients tested from these 3 centres, which is great. I mean, so this means that more patients are being tested using an appropriate test like whole genome sequencing for these really important clinical indications. And as I said, most of those are the paediatric clinical indications. So that's our big trusts in our region. But what about everybody else? So this is the other trusts that have been submitting whole genome sequencing. I don't think we've, I think we're missing some of the labels there, so I'm really sorry about that. But this is going to give you a flavour of the numbers of tests that have been submitted. So this is 2021. If we do the next slide, this is 22. And this is 23. So you can see there were a number of trusts that are now submitting about 70 patients per year. But all of those trusts were only submitting 10 or less patients in 2021. And so we're having a real expansion of the number of patients that are families that are being tested through WGS, and the availability of that WGS throughout our region. And as I said, this is, there's a huge number of things that have been behind the scenes of this, including paediatric forums, including education by the East Genomics team, but education by all our clinicians and in clinical genetics services. And we've got champions of genetics and genomics across our regions. So thank you if anybody's been championing our WGS service across this region. So if we look at that equity across our region, what we could see is that I think we've got 29 trusts across our region, and you've seen this map before. We've got 17 acute trusts, but 12 community and mental health trusts. And in 2022, 11 of those trusts hadn't sent any WGS yet. But as of last month, we've now only got 2 trusts that haven't sent any WGS. So this is really great. You know, we're really making an impact on the number of patients that have access to whole genome sequencing through this mainstreaming effort. So very quickly, thinking a little bit more about access to testing and how effective our testing is. So a trio family structure is the best way to submit testing for whole genome sequencing, especially for the paediatric disorders. So this is a parent, 2 parents and a child, an affected child, unaffected parents, and that can give us a really good likelihood that we'll find a genetic diagnosis in that family. So as I said before, the paediatric disorders and the intellectual disability clinical indications represent a huge volume of our testing, and that's about 50% of our testing. And you can see over time the proportion of trios that we've been receiving for these clinical indications has remained around 60%. So that's really great. So our new referrers are ordering trios where they can, and our existing referrers are also sending trios and continuing to send those trios in, which provides the best likelihood of a result for that family. So that's brilliant. And then just quickly to think about the diagnostic yield that we're getting. I'm sure you know we've looked at this data about how many patients are being tested, but you know how many of those patients are getting a result, those families are getting a result. So same again, looking at these paediatric disorders and the intellectual disability clinical indications, you can see that our diagnostic yield in the East is just sitting at under 30% for the paediatric disorders, and about 26% for our intellectual disability. And if we go to the next slide, please. And you can see that if I compare that data that we've generated in the East to the rest of the genomic medicine service, then we're seeing a really a similar diagnostic yield for these patients. So this is a huge number of families that are receiving a diagnosis, and unfortunately a lot that aren't, and we might get to that in a little bit. But I think this really shows that the testing that we're delivering and the referrals that you are sending to us are providing that opportunity of testing for those patients. So I've just got a little vignette. So we've looked at those really high volume tests, but I just wanted to touch on the sudden cardiac death pathways that we started to introduce. I think Guru just mentioned it before, and I think Dick's going to talk about a patient story a little bit later. But we have these new clinical indications that we're delivering through whole genome sequencing. The sudden cardiac death pilot, we've got funding for another year for this pilot, and this is a collaboration between East Genomics, the University of Leicester, the Coronial service, pathologists, clinical genetics, and the GLHs. And as part of that project, we're sending some patients who are deceased for whole genome sequencing. And that information can provide really important information about how those patients died, and also important information for their families to receive cascade testing to see if they have the same conditions. So through that pilot so far, we've tested 3 patients through whole genome sequencing. And this was really the pilot project for delivering this as a routine service. And since last year, we've also had a childhood death clinical indication just delivered as a routine service. And we've received 5 patients so far and tested 5 patients for this. And so I hope these numbers are really low, but what I think it shows us that we're able to introduce and to provide opportunities for testing for families in this really difficult situation where they've had a child or a family member who has had a sudden death. And so I think this really shows how we're not only providing genetic testing to the whole region for whole genome sequencing, but also just these very specific areas to ensure that these patients have the best chance of having a genetic diagnosis. So I hope today what I've given you is a little bit of a flavour around equity of access of genetic testing in the East Genomics region and the whole of the Genomic Medicine Service. We've talked about how we standardise testing and centralising this whole genome sequencing service, how we're mainstreaming that, and I've also touched on these new pathways that we have for our sudden cardiac death patients. Next time I see you, let's talk about reanalysis and research. Sorry, I've just run out of time.
Thank you very much, Kate. Our next session is on the building capability and capacity theme, so supporting healthcare professionals, education and training, and this will be delivered by Dr. Gemma Chandratillake, who's our education and training lead at East GMSA, and Dr. Lucy McKay, CEO Medics for Rare Disease. Welcome to you both.
Thanks, Emmanuel, for that introduction. And brilliant. Thanks, Ian. Okay, so when we're thinking about supporting healthcare professionals to incorporate genomics into their practice, it's helpful to sort of take a step back and think about the scale of the NHS workforce. So the NHS is the largest employer in Europe, and it's the 5th largest employer in the world. And as you will all know, it's not actually a single entity. We've got lots of different entities within the NHS. So the issue with this is we actually have a very small number of people within the system who have genetics or genomic expertise. So we have a couple of hundred clinical geneticists and a few hundred genetic counsellors or nurses. So we know that genomic services have to be delivered by non-specialists in genetics, and that concept is known as mainstreaming. So by mainstreaming, what we are recognising is that not all healthcare professionals need to become genomic experts, but they do need to know when testing may be relevant for their patients, and they need to know how to request it and how to have conversations with patients and their families about the results and support them once those results come through. But we knew from regional surveys and national surveys that have been carried out in 2016 and also regional surveys that we had done in 2021 that we had a lot of work to do on this front, because there was a real lack of awareness of genetics and genomics amongst the mainstream healthcare workforce. There had been a lack of training. Genetics just wasn't in people's training curricula. There were opportunities to train, but the mainstream workforce were completely unaware of those opportunities, and people really perceived genetics and genomics as being irrelevant to their role. And these are just some of the comments that we received back when we were surveying. We had a survey of over 1,000 professionals in the East, and people would say, I don't even know what that word means. I don't know what it involves. I'm not aware of this field, or my role doesn't involve that. So that was the kind of status in 2016. So from that point forwards, we've been working really hard at both national and regional level to try and move the dial on that. So there is a national genomics education program. You can just Google genomics education program and you will hit their website. That team, they have taken a multidimensional approach. So they've been really involved in sort of workforce planning and development, thinking about how to incorporate genomics into training curricula, working a lot with, for example, the Royal Colleges. They've created a lot of educational opportunities by making central resources. So there's lots of online courses and things like that. They've also commissioned master's programs, and they've been doing a lot of work on social media to raise awareness and with various different professional groups. So this is just a kind of outline of the types of work that they have been leading on. So at the top of this pyramid, we actually have some formal training programs, and this is really focused on increasing the numbers of specialist workforce in genomics, so that increasing the number of scientists and laboratories, increasing the number of genetic counselors and clinical geneticists, and trying to deliver that training at scale and in a streamlined way by having a national training academy and national training programs. We then have formal education, so they have funded master's programs around the country. In our region, the University of Cambridge is a provider, but people from our region can go to other universities as well. Some of these universities offer their master's program remotely, and so healthcare professionals are funded. So if you work for the NHS, you can receive funding to take the modules of the master's program. There's lots of online courses as well, so MOOCs, like massively online courses, and various e-learning programs that you can just access through this website. There's lots of resources for people like me to use, so there's lots of animations and fact sheets and cartoons and diagrams so that we can train efficiently and don't have to draw everything ourselves from the beginning. And then there's lots of, as I say, awareness raising through social media, etc. These are the genomic medicine modules that are relevant if you are working in any area of medicine, really. So any area of medicine, you will encounter patients with rare conditions or inherited conditions. So we would really encourage you, whether you be a nurse, a doctor, a pharmacist, a midwife, an allied healthcare professional, to partake in modules of the genomic medicine program. You can contact the team at Cambridge, or you can go on the Genomic Education Programme website to find out about the other universities. These are some sort of generalist modules that I would encourage you to take. The top 3 I would consider to be really essential for anyone who is working in medicine at all, really, for all nurses, doctors, regardless of your specialism. There's also a just-in-time educational resource for healthcare professionals that has been developed called GeNotes. So it's being rolled out for all different medical specialties, and you can just access this on your computer or on your phone. It's not an app yet, but it will be at some point soon. These are the areas that have been developed so far. So if you are working in one of these areas, please do check out GeNotes and just have a quick look at it. I put actually a link from GeNotes for familial hypercholesterolaemia during Javier's talk earlier into the chat. So there are lots and lots of health conditions that are covered there, and lots of clinical guidance for clinical teams, just what to do, what testing is available, what you should be asking your patients, etc. Okay, so we're also thinking in East Genomics about how to get training into our regional training. So we've been thinking quite a lot about medical training, for example, and we've been working closely with both the deaneries in the East of England and in the East Midlands. So if you think about how a doctor trains, they go to medical school. We're hoping that genetics is being incorporated into medical school curricula. But that's not been our focus. What we've been doing is picking up when people get into those foundation doctor years. And this really gives us an opportunity to cover all doctors of all future specialisms, including primary care, in one go. So we've been running foundation training hubs in genomics since 2018. We run half-day events about 4 times a year across the region. We're then working with the deanery, looking at their training programs, trying to ascertain which training programs have already incorporated genomics and which ones need a bit more help, and monitoring this over time. But we don't stop with the trainees. Of course, trainees train under consultants, and so it's important to reach the consultants themselves in order to affect patient care today. So we've been really exploring the community of practice model. We've got 2 East community of practices running now in paediatrics and prenatal care. And I'll be talking a bit more about that tomorrow. So if you're interested in communities of practice and how that can impact at scalable level across the region, do tune in tomorrow, and we'll talk about the ones that we've established so far. We've also developed a few e-learning modules as well in our region. So we have an e-learning around discussing whole genome sequencing with patients. So we do ask that all clinicians who are ordering whole genome sequencing would take that e-learning module so that they can have really good consent conversations with their patients before they order those tests. We've got genetic testing for hereditary breast cancer available for breast teams across the region, inherited cardiac conditions. We also have an e-learning on that. We've got genetic testing for carrier testing in primary care available as well. And we have a prenatal testing course as well that will be coming online shortly. So if you're in any of those areas of medicine, do check those courses out. And I think that's the end. And I'm going to be passing over to Lucy now, who's going to hone in on some of the educational material for rare disease specifically.
Well, hi everybody, I'm Dr. Lucy McKay. I'm representing a charity called Medics for Rare Diseases, which you can see at the bottom there is our logo. So I'm going straight to my my sort of declaration slide, which is to say thank you to our sponsors, but just to let you know that they don't have any control over the content of this talk or the charity itself, but rather just support the overall work we do. So what is Medics for Rare Diseases? Just in case you don't know, I'll be super quick. So our vision is that we have a world in which no one faces inequity in healthcare based on the prevalence of their condition. And so therefore, to do this, we need to build a healthcare workforce that is trained and supported to meet the needs of those impacted by rare conditions. And just if you take one thing from this, it's that rare diseases are individually rare, but collectively common and have common challenges. And genomics and diagnosis is only a portion of rare disease challenges. And therefore, when we're thinking about genomics and rare disease, we can't see them as one and the same. People live most of their lives outside the context of the actual genetic or genomic diagnosis. So we provide training for doctors about managing their patients with rare conditions and those impacted. So I just want to make sure we're all on the same page, because I'm not sure how much we've really got into this yet. What is a rare disease? So if you didn't know that it's fewer than 1 in 2,000, don't worry, you are not on your own, because what we have found whenever we survey healthcare professionals is that most people think a rare condition has to be fewer than 1 in 2 million to be rare. But actually, there's a lot of familiar conditions that you know of that really fit in the rare bracket. 70% have symptoms that start in childhood, and 72% have been identified as having a genetic basis at the moment. Really important for the context of here, not all of those will benefit. Those with a genetic basis will benefit from whole genome sequencing, because of the nature of it, but also just think of the number of people where their rare condition doesn't have an identified genetic basis. So that's how you know this is a Venn diagram, we're not overlapping. There are more than 7,000 rare conditions that have been described, and this includes all childhood cancers. So when we're thinking about rare and whether it matters, think about what we think about rare cancers in childhood. And only 9 rare genetic conditions are currently screened for at birth in the UK using the day 5 heel prick test. And I just want to say at this point is that earlier Professor Aithal said Professor Guru said that that the workforce is far from ready for it in context of genomic medicine, and that we're taught common things are common. Gemma just mentioned about what's happening at medical schools, and actually when there's been quite a lot of surveys about this, that low confidence in even identifying a patient for testing, for genetic testing or any kind of testing, you're not the only ones who have low confidence. There was a Medscape survey of nearly 1,000 clinicians in 2021, and about 20% of those were from the UK, but the results were pretty similar across with the EU5 and USA. 81% had low confidence in even recognizing rare disease. And those clinicians who had high confidence in making a rare disease diagnosis were significantly more likely to be able to define what a rare disease is. Because actually it's really, really difficult to spot something, understand it. If you don't even know what it is, you can't even define it. And 71% of paediatricians reported that they never or rarely see patients with rare diseases, which just seems very unlikely, considering most scientists I know would never say never. And 91% had a low confidence in diagnosing patients with rare diseases. So when you're thinking about who might present with a rare genetic condition, these are really worrying statistics. Medical school is frequently brought out as the place where healthcare professionals learn about rare disease. And yet we've already discussed today about being told common things are common, and the fact that very little in strategy and policy has any power over medical education at undergraduate level. Medics for Rare Diseases did a survey of medical students across the 4 nations last year, and there was no significant difference in their objective understanding about rare disease, whether they've been taught about it in medical school or not. So whatever medical schools are doing, it's not informing them about 1 in 2,000 or childhood symptoms, cancers. They can't answer these questions. The people who could answer those questions were people who identified as being part of the rare community. So 3.5 million people in the UK live with a rare condition. So globally, the prevalence is about 6%. So they're individually rare, collectively common. Everyone here in this slide has a rare condition or is impacted by a rare condition. Rare is many, and it's very different. And therefore, we have to sort of have a very open mind about who walks in the door, might have a rare condition, might have a rare genetic condition. So let's think about those common challenges, because while it's varied, there's over 7,000 conditions, there are common challenges related to living with a rare condition. A bit like in cancer, you can have very different people with very different cancers, but we can still provide a cancer MDT, a generic cancer MDT. We can still provide generic cancer support. One of those is the diagnostic odyssey, which is really where genomics comes into the fore. And it has to be seen as a tool. It's not everything. First of all, you have to get your clinician or your healthcare professional to understand the need for genomics in the first place, which I think has already been shown. That context, it has been lacking, especially given the stats I've told you about medical school. You can't expect you teach your healthcare professionals, it's so rare, don't worry about it, and common things are common, and then suddenly expect them to take up one of the most new and complicated sounding tests there is in the NHS. It just can't happen like that. So the diagnostic odyssey is something I won't go into now, but the diagnostic odyssey isn't just about it being a long path to diagnosis, it's a difficult path to diagnosis. It breaks people, it really does, and that's what we need to take out of it. I'm not for fast, I'm for timely and supported diagnosis. So, common consequences of a long diagnosis and the diagnostic odyssey. Thank you to Rare Minds for this report, which they brought out this year. Isolation, experiencing stigma, not being listened to, feeling not believed, not being listened, loss of trust in healthcare is a major one. So then when we suddenly come in and say, oh, we've got this quite difficult to understand test and we want to, do it for you, maybe there's going to be reticence potentially if people have not always believed in healthcare and trust that healthcare is there for their benefit. Loss of education or employment, which, remember, are human rights. If people are missing out on education and their chance of a family life and employment because of the lack of a good pathway, an efficient pathway to diagnosis, the NHS is impinging on their human rights. Burden of explanation, which is a phrase that I have borrowed from the anti-racism teaching. When someone has a condition that even the doctors, there might be one doctor in the country that knows about it, they have to explain themselves over and over and over again. And it's a real burden and it really impacts people's mental health. And out-of-pocket expenses, who's paying to go from test to test where there's no NDT? And just imagine if we did that to patients experiencing cancer, there would be outrage if they're having to go to multiple places across the country to find specialists to do different tests all on different days. And it really does, I cannot stress enough how the lack of healthcare professional awareness and then the inability to manage that uncertainty when you've got no one, feeling like no one's on your side, really adds to mental health burden. So we've got to talk about expert opinion. In rare disease, we might be talking about cystic fibrosis and sickle cell, or we might be talking about a diagnosis that only has been existing for a year because we now know the variant thanks to genomic medicine. Expert opinion needs to be really carefully considered about who's an expert in what. So this is not really to get too far into, but I just want to demonstrate this, that there's red flags. These two people are carrying red flags, right? But they look very different, like red flags. One is smaller, one is triangle, the other one is a rectangle and it's shorter, but they're still both carrying red flags. And they're only really going to be able to look at what they know and understand, their expertise. We have to combine expertise. So on the left is a paper published quite a long time ago now, but by a great group in Australia, Waveney et al., on how to think genetics in primary care. And you can see, you know, it's family history, and then it's got this acronym, and the experts in this were all clinicians. Over here on the right, you have a publication by Medics for Rare Diseases and our collaborators about red flags as reported by the patient advocacy community. So red flags of being undiagnosed, when to think rare. The patient or the advocacy group are talking about how they've got lots of symptoms. It's their experience, it's their story. Maybe family members, they're not going to come in and say, I've got a family history. You have to be asking those questions in a sensitive way, thinking about how it impacts school, thinking about how I've said it impacts work. Just an explanation that just doesn't satisfy. This just doesn't make any sense. And that feeling of, hang on, you've been misdiagnosed over and over. So how can you have assurance in this diagnosis? These are all things that came out as red flags of an undiagnosed rare disease. I don't know the day that a patient's going to come in and say, I've got a group of congenital abnormalities. And we have to be thinking that we're working in the reality of 2024. Maybe in the past, a doctor has the time and resource for every patient that who've got medically unexplained symptoms or they're just not sure about, to do a full workup like this. But I just don't think that that's the reality of 2024. So what we need is to listen to the experts who have gone undiagnosed with rare and genetic conditions, think about what picture they will present, and let that be what helps your healthcare professional go, actually, I think there's something that we're not getting here. There's something underlying. And at that point, get them to do a really excellent family history, a really excellent medical examination and history, and then thinking about testing afterwards and combining expert opinion, because in rare disease, there is rarely one expert, and it's rare. People rarely have a lot of experience that would cover the whole gamut of what's going on. Next slide, please. So what we're doing is building this approach, this integrated approach. On this slide, we have some of our ambassadors. Some of them have impacted by a rare condition personally or their family. Some of them are healthcare professionals. Many of them are both, because actually those two things are also a Venn diagram. And what we do is bring them all together, because we're always learning off each other. And this integrated way of the person with the lived experience, but the person who can facilitate healthcare is really important. And that needs to, one discipline of rare disease perspective needs to start from the beginning of training and go all the way through, because the patients have to drive rare disease in a way that is also important in other areas of medicine, but may not be quite so crucial to just getting anywhere. And I just want to say a huge thank you to East Genomics GMSA. I think you are trailblazing in terms of working outside and with external organisations. You're a voice for the patients, you're advocates, and Gemma and Ian, you've done so much for Medics for Rare Diseases. Lastly, we've got online learnings. we do adapt them for other places. So if you like them and you want to use them, we can adapt them. And also make sure you do check out Genomics and the JET program, who we've been really grateful to partner with to bring rare disease education into genomics in the overlapping Venn diagram. Thank you.
Thank you, Lucy. A sobering reminder of some of the challenges that remain. The next section is a series of case studies, so improving services, and we will hear from 4 speakers. So the first is Fragile X Clinic at UHL, and this will be delivered by Professor Julian Barwell, who's a consultant clinical geneticist at University Hospitals Leicester. Second case study is on ophthalmology that will be delivered by Maz O'Reilly, who's a principal genetic counsellor, Nottingham Universities. And we've heard a bit about sudden cardiac. Professor Dick Sandford, our clinical director at East GMSA, will be providing an overview of the national project, the improving the identification and outcomes for individuals with inherited and acquired cardiovascular disease. And lastly, we'll hear from Aris Saoulidis, who's our clinical pharmacy lead at East GMSA, and he'll be talking about mapping patients' genomic testing journey, patient engagement project on understanding the diagnostic and treatment odyssey in genetic disease. Kick off with Julian. Welcome, Julian.
Thank you so much. So here I am in research space in our Fragile X hub, and thank you so much for the last series of talks. This really builds on the concept of supporting people with rare diseases in a holistic way, and really just trying to reinforce the point that Fragile X diagnosis is not the end of the journey for someone. It's the beginning of hopefully being able to help that individual and crucially the family as well. So this story in a way began when I met with Chris and Alex McQuaid, who had 2 sons who were diagnosed with Fragile X. Here we've got Evan and Xander, 2 lovely boys. They were on quite a diagnostic odyssey originally when Evan was running into difficulties, which turned out to be Fragile X. But they didn't get a diagnosis until both the boys had grown up a little bit and had never got that chance to discuss reproductive health choices after their first child was born, even though there was a family history of autism on mum's side of the family. And they went on through genetics to have a further child through PGD, didn't have autism or Fragile X, but were struggling to find where to access support. And they came to me, and that was really because I had done a lot of outreach and holistic work in the cancer space that I will mention, but also I have a personal history in my son with autism, and his best friend had Fragile X. So this was certainly an area that I felt very passionately about, and I'd received a lot of very good support for my son over the years, thinking holistically, and also for my daughters who don't have special needs, but just being really mindful of the impact of special needs on the family unit. And what I'm going to do today is talk to you through the journey of how we've been moving towards the Fragile X hub. So as I said, I've already got some personal skin in the game, and I'd written a paper within our department called the medical supermarket model, which was an holistic approach to cancer survivorship, where we would have some of our genetic counselors, but also psychology, physiotherapy, smoking cessation teams, the CRN, stakeholder groups. And there'd be 1 or 2 talks at these evening or weekend events but then people would walk up and down the stalls finding information that would be useful for them. And this was available to any of our patients in the familial cancer service. So all of our patients had access to a dietitian, physio, psychology, psychotherapy. And it didn't, interestingly, it didn't create lots of additional work. We also spent many years getting the funding for research base, which is where I am right now, which is a unit. We're now in a quiet room here, which is used for consent and chill out zone for children with autism, but we have interactive floors, and we've got specific rooms for procedures as well. Also, my wife and my eldest daughter work for Relate, which is the old marriage guidance group, and we're very mindful that apart from the impact that Fragile X can have on carriers, because remember, carriers can have symptoms as well. In fact, we move away from the word carriers and talk about Fragile X spectrum. The grandparents may have ataxia, which is confused with Parkinson's, but it can cause premature menopause, as well as anxiety in female carriers, as well as autism, agitation, sometimes aggression, and apathy even, as well as the additional needs in affected children. So when Chris came to talk to us, we'd already done a lot of work in outreach and co-creation space, and trust is absolutely key. And so with Joe Lowry, our genomic project manager, but also with Maria, we helped work in the United Against Prostate Cancer space last year, where we talked in the Peterborough event. But we've also been involved in developing a digital portfolio, a teaching portfolio for postgrads, but also we have a school outreach program. And Nita, one of the consultants who works in the Fragile X space with me, and I put together a book, What is DNA?, which answers questions like, why do I hate Brussels sprouts? Is granddad a dinosaur? What came first, the chicken or the egg? So we've done a lot of work with communities, and we feel that this is absolutely important, that we think not only holistically about patients and their families and integrated, as Lucy mentioned in the last talk, but we also work with families to bring communities together and think about the educational requirements for the family, occupational therapy, as well as the impact on relationships. So we know, for instance, that almost half of couples break up within 5 years of an autism diagnosis. So it's not just thinking about the couples, but it's also about thinking about the siblings as well. Next slide, please. So we met, Chris reached out on a Friday, we met on the Saturday with Chris and Alex, and we went through what's it like to have children with special needs. They're sort of 10 years behind my personal experience. And we talked through what it would mean for the individual, the children, the family, and types of things that you might want to think about. And it was at a stage where we'd received the diagnosis over 10 years earlier. And I felt now in a position where I could potentially give back some of the experience that I'd had personally, but also to take on board a lot of the learning that we'd done through holistic care, through familial cancer, and apply it now that we had research hub, research-based, dedicated pediatric and adult research facility to be able to offer research opportunities. And this is about how we've used research studies to underpin and help drive the development of the hub moving forward. So really it was about a series of minds coming together at the right time. Chris and Alex are superb energy. They've got personal skin in the game and incredible networking skills to help bring together different groups. And we started by looking for research, interventional research opportunities. And we were amazed at how many projects were available internationally that we could get started. And we started with the Reconnect study, which is a placebo-controlled double-blinded study with a cannabinoid gel. And we've seen great progress in 80% of the children. And we've been the #1 recruiter to Europe. But it's opened up links to a number of companies and opportunities. And there's real interest in gene therapy moving forward. So this is very much about getting your rubber ducks all lined up. It's having skin in the game personally and having co-creation with families who know what it's like and are keen to drive this forward. It's about having the research infrastructure available and companies that are keen to help drive with you this research agenda. It's also about following the science and making sure that there is scope for growth and people can see the opportunities moving forward. So once you've done that, we then apply to Leicester Hospital Charities, and it's a huge thanks to them as well, to run a series of conferences with stakeholders. And this is to find out what is important for families. What are the concerns that families face? And we've got families there who'd received a diagnosis of Fragile X over 40 years ago. And they've been there, done that. And we met and we created a vision statement, a shared vision as to what we think the Fragile X hub would involve. So do we need one? What are the problems that people face? What types of professionals should we have as our primary professionals within the hub on the day, but also the people that we could refer to if they have very specific problems. Also thinking about the needs of the mothers as well with their premature menopause or their anxiety, as well as their grandparents, thinking about the genetic and genetic counselling needs, but also thinking about physiotherapy, OT, and psychology as well. I've done a lot of work with the Rutland Rotaract Family Support Centre and support a lot of families with additional needs in the community. And they do things like horse riding and swimming and a lot of additional types of activities to support people with autism and to help build independence. And I think it's really important to think, what are the challenges that families face when they get a diagnosis, and what are the types of questions that they ask? And obviously early on, thinking about the cascading of information, reproductive risk, and reframing their life hopes and dreams is important. But in the longer term, people are thinking about independence. And part of that may come through occupational therapy and social and society support. But also there's a lot of interest in therapeutics, which can either improve mental health or potentially your cognition. One of the challenges is that a lot of families struggle to access CAMS to be able to get a diagnosis, an additional diagnosis of autism and ADHD. And this is something that we want to look at, as well as the challenges of people being able to access medication. One of our pillars is that we do feel there's a lot of unmet need with anxiety. Now, that doesn't always require medication, and we're well aware of that. And we've helped write a review with Sam Trumans, who's a consultant in adult learning difficulties, who's helping us support our Fragile X Hub. And we appreciate that some of this is going to require social solutions, allied health professionals, and that's why we're building the case of need with them in mind, as well as driving forward all of the medication as well. So I wanted to thank Vicky, who's our brilliant lead genetic counsellor, who's helping us with our case of need, and all of the people on this talk. We've been looking at challenges and mitigations and our vision, true co-creation, holistic integrated care, research opportunities, whole families being considered, reducing the pressure on CAMS, and putting us in a position where we can actually bring in further research and gene therapies. And that will come from getting better metrics like the NIHR toolbox moving forward. Thank you very much. And I'll be around at lunchtime for any questions. Thank you, Emmanuel.
Thank you, Julian. Handing over to Maz. Maz?
This project aimed to introduce mainstream genetic testing at Nottingham University hospitals as a pilot. So if you'd like to pop on to the next slide, just to give you a bit of an overview, eye genetic conditions are really heterogeneous. There's over 900 genes involved with these conditions. Collectively, however, they cause a significant impact to children and working age adults in terms of vision loss. And they can be grouped into 4 major categories. So we've got structural and developmental conditions, retinal disorders, corneal dystrophies, and optic neuropathies, broadly speaking. The way they're handled, or the way these conditions, these genetic eye conditions, are managed currently is through some specialist centres as well, which I'll go on to in a minute. So since the National Test Directory was implemented, a greatly increased number of genetic tests has been possible to order, and so there's 13 different panel tests. So this is pretty complex, and often choosing the right test needs expert review of a person's actual test findings. And moreover, the majority of these tests require trio samples, so sample for children from child and both parents, to be able to use whole genome sequencing. So the interpretation often needs specialist input as well, and there's often a lot of variants of unknown significance which are found as a result of these tests. Sometimes it needs for additional testing in family members as well. So why do genetic testing? Why attempt it? So from a genetics perspective, it's a no-brainer. We know that this is a future way to help clarify risks for patients, give them reproductive options, and it's something that also the Royal College of Ophthalmologists supports as a position as well. So across the UK, there are around 15 different centres who will see patients with genetic eye conditions. Mainstream, in a sense, is not really working in its truest form, in that these centres generally will have some of them will have an embedded genetic counsellor who might work part-time for the centre and then do a different role other days of the week. But generally the testing is done in parallel. So there are eye specialists and there are geneticists working sort of in parallel. And it doesn't provide the wider educational opportunities sometimes that mainstreaming does. And we're aware, just anecdotally talking of large cohorts of particular patients who are not actually ever offered genetic testing. We know that another model, which is an emerging model for genetic testing, is to use all of the benefits of our nurse specialists, and this is something that's particularly happening in the field of genetic cancer testing. Huge programs of education and engagement are happening. And when we set this up, we thought that would be the model that we would use. But actually, we identified an emerging, very enthusiastic clinical group, and these were the orthoptists. Now they are, there's a little quote here, but orthoptists are very key in a patient's pathway, highly trained professionals, and have some of the key skills, or have a lot of the key skills needed to deliver genetic counselling. And so this was where we went next. Now I'm just putting up here, I think it's really helpful when you're setting up a local project to reflect on some of the really key steps that are important to make something work. And I'm not going to go through all of this, but to say that I just wanted to focus on a few. And one of these was to actually get buy-in from the ophthalmology team from the off. And we were very fortunate in that we had a very enthusiastic clinical lead, and that helped to sort of smooth the pathway to get buy-in from operational managers. And there's a lot of the detail here is actually really important. to get things going, we actually set up some fortnightly stakeholder meetings as well, and as a driver to make sure that this could be looked at above all of the other competing needs for a very, very busy service. We were funded, the East GMS funded us for both genetic counsellor time and clinician time from the ophthalmology team, as well as admin time, which really helped us to think about all of the different elements needed here. As well as engagement for the local team, our genetic counsellor put together a training and education package for the orthoptists, and that using available resources. And on the end of this slide set is an appendix which has got all of the resources that we use, which we felt might be useful for anyone else who is contemplating doing this as well. Obviously, we need to think about the referral pathway, and again, this is going to be different for every service who sets something up like this, but we needed to think about a really straightforward way, such as how to order tests, return of results, governance, very, very important governance, so that the service felt secure doing this, and also inviting parents and how to retain their data while testing was ongoing. A couple of things that came up as real issues for us is the fact that as a trust, until next month, we weren't routinely using net accounts, and these have to be specially requested. So one block there. Another block was that the eye department were not routinely using video clinics and didn't have the knowledge to set that up. So we had to provide specialist knowledge, because these can all be remote clinic that are used for consenting. Another element that we had to think of was how to move from a project to transition this into business as normal. Obviously, this required supporting the service to write a business case and helping them to provide evidence. And when you've only had a project running for a few months, they don't have the results there to provide evidence. But we were able to look at previous tests that have been done by with the support of our own service, look at pickup rates, and the team were able to estimate some of the unnecessary reviews that were happening in specific areas, and that gave enough evidence for us to for a fixed term business case extension, so that the sort of proof of principle can be extended here. So here are a few of the challenges that we came up with, and I've mentioned some of them, but I think it's really important to not downplay these. This was a very, very active project, which involved, as I say, fortnightly meetings, fortnightly catch-ups, so that we could help to iron out at all stages of the process the issues coming up. However, it was worth it, and the next slide shows some of the benefits as well. And I think that there's a couple of elements I wanted to just raise here. So we know that for R32 panel, just on estimate, there was a 53% reduction in appointments for clinical genetics. We know that there is, in the team, there's an increased awareness. The work that the orthoptists have done in educating the wider team has improved the referral rate and the number of consultants referring for genetic testing now, and has made it much more straightforward because they can talk to a colleague about how to refer. And we have an electronic pathway that they can refer to very straightforwardly, embedded in the trust care flow system as well. So where do we go next with this? I've mentioned that we have a fixed term business case at the moment, but obviously ophthalmology, we will be supporting them to look at the longer term survival of this pathway now that it's all embedded and the training is in place. That there has been some interest from other trusts, and we'd be delighted to support any other trust who like to look at implementing this locally. And we think that we have got a very useful model using orthoptists as the clinical group to provide mainstream genetic testing. And I think I'm just going to move on to our acknowledgements. So huge thanks to everybody, and Aditi, our genetic counsellor, and Sophie, our genomic practitioner, who supported here. And I also would like to particularly mention our orthoptists, Almini and Rebecca, as well as the clinical leads, and Isabel, the operations manager, who was also very instrumental in getting this off the ground and into working. And finally, our GMSA support from Lucy and Cole Spencer, and for funding this in the first place. Thank you very much. The last slide just has an appendix of the training if anyone would like to access these in future.
So several of the speakers already have alluded to the sudden cardiac death program that's currently being undertaken within the Genomic Medicine Service. So what I'd like to do is to put a little bit more detail around that program of work, and just to highlight really a project that has started off as one of the first national transformation projects in the Genomic Medicine Service, and how that's now progressing towards what we hope will be formal commissioning within the NHS as a new genomic pathway. So I just really wanted to introduce this on behalf of Professor Elijah Bear, who's the study lead in St George's in London. This was co-delivered and is still being co-delivered between the East and the South East GMSAs, and supported and funded by the British Heart Foundation, with critical support from the patient charity called Cardiac Risk in the Young. So this is a big team effort. So next slide, please. But of course, the obvious question is, well, why sudden cardiac death or sudden unexpected death? Well, let's just pause a little bit to think about what that exactly means. So there is a broad definition to sudden unexpected death, and that is a witnessed sudden death within 1 hour of the onset of symptoms, or an unwitnessed death when an individual has been alive and well within the previous 12 to 24 hours. And sudden death such as this is actually about 15 to 20% of all deaths worldwide. And you can see that probably the majority are due to the existence of ischemic heart disease, coronary artery disease, but a proportion are due to other causes. So those are principally going to be cardiac muscle disorders, and Guru has already identified some of those, so the cardiomyopathies. But a small proportion remain unexplained even after extensive investigation, and that proportion is approximately 3 to 4 per 100,000. So the numbers may be small, but as you can imagine, the impact on the wider family is severe. And so this particular program of work was bringing together specialist services, including the Inherited Cardiac Conditions Clinic, because a lot of these other causes and sudden unexplained deaths, for example, were likely to have an underlying genetic cause. It needed to bring together the specialist cardiac pathologists, the genetic testing laboratories, the GLHs, and also the coroners, the Coronial service, where of course these deaths are more than likely to be initially notified. And of course, there is good data now underpinning all of this. I've just put a few examples up here. So when an autopsy is carried out and there is a structural abnormality in the heart, such as a cardiomyopathy, hypertrophic cardiomyopathy would be a common one, we know that there are approximately a third of those cases will have an underlying genetic cause identified if post-mortem genetic testing can be offered, if there is an available DNA sample from the deceased individual. So a significant return on genetic investigation. And for those individuals, again, sadly, succumbing to sudden unexpected death, sudden arrhythmic death syndrome, SADS, we now know that post-mortem genetic testing is potentially able to pick up some 10 to 15% of causes. So giving a clear clinical diagnosis, which obviously is going to have a very significant impact on the ability to advise, counsel, test and screen family members who are potentially at risk. So that really is some of the information sort of underpinning the background to the NHS Coronial Sudden Unexplained Death Programme. So you can see that cardiac pathology, post-mortem genetic testing, and clinical familial evaluation are going to be the three primary components of a comprehensive and personalised medical management for families who've suffered the tragedy of sudden unexpected death. And again, a significant proportion of that is due to an inherited cause, as we've heard. So the aim of personalised medical management is to identify the cause of death and diagnose and treat relatives who may also potentially be at risk of some of these genetic disorders. The delivery of an appropriate patient pathway is, however, at the moment, very, very heterogeneous and variable across NHS England, and clearly requires close working between the NHS and coronial services. The one very, very significant gap in this is the ability to obtain a DNA sample from a deceased individual such that genomic testing can be offered to advise family members. And so the implementation of the genomic laboratory hubs and the GMSAs across England provided a key opportunity to explore the impact of systemic and post-mortem genetic testing for sudden unexpected death. So hence this particular programme of work. So the objectives of this particular transformation project were to establish a consistent pathology referral practice for sudden unexpected death, including the use of expert cardiac pathology, and above all to establish routine tissue retention, not just for histopathology, but also for DNA extraction in suitable sudden unexpected death cases, such that the offer of genomic testing could be made at a future point in the pathway, to establish coronial and NHS pathways for referrals, for seamless referrals of families for genetic testing and clinical evaluation, such that there wasn't the opportunity for these families to be particularly lost in the system at a time that was obviously going to be extremely difficult for them, to establish the mechanisms for standardized post-mortem genetic testing and reporting via the NHS GLHs, and to support timely evaluation and cascade testing of families. This was delivered through an initial pilot programme of 7 centres, one in each of the national genomic medicine services, but it needed to be scalable such that national delivery was feasible, and to develop and disseminate nationally applicable best practice pathways for the eventual NHS adoption, employing what we describe as a toolkit approach. And of course, the engagement and input of patient and support groups with an interest in this particular area. And that again has been critical to the development of this particular pathway. So these were going to be the appropriate cases reported to the coronial service. We also now include individuals who have suffered cardiac arrest, either where resuscitation has failed or there is no recovery despite an initial successful resuscitation. So that can also include both out of hospital and in hospital cardiac arrest. A very broad age range there, although typically a lot of the inherited conditions are often going to present at a younger age, or where there is a clear clinical suspicion of an underlying cardiac genetic cause. And in addition, as I've already suggested, where full coronial expert cardiac pathology and toxicology testing has identified a diagnosis of sudden arrhythmic death syndrome. So in terms of thinking about how this pathway was delivered, and this is a snapshot of the various initial steps that were set up. So it included a process whereby all stakeholders were engaged, where we developed the tissue retention consent form that was adopted through the coronial services to allow tissue storage for DNA extraction to occur. The process whereby we could signpost to the inherited cardiac conditions services to develop the appropriate resources for family and coronial education, the engagement with the coroner's officers themselves, and access to specialist cardiac pathology being available to all these services. And the key to delivering of this particular new pathway was the appointment of inherited cardiac conditions coordinators to link all of the communication between the coronial service and the ICC service. So those have all been put in place in the pilot centres, and external evaluators have also been appointed to review the pathway as it is being developed. And that now looks like this particular pathway. So it's as I very much described. So there's the initial notification to the coroner, who instructs a post-mortem to be carried out, which will include specialist cardiac pathology. And then when appropriate, the coroner's officers and the coroner himself have highlights a cause of death as a potential inherited cardiac condition or sudden arrhythmic death syndrome, the coroner's officers can signpost the family to the inherited cardiac conditions clinic and retain tissue, and that is done through sharing information with the bereaved family to enable that information to be passed to the ICC service, and that is carried out by the ICC coordinator, as I've already described, and they are able, with the appropriate consent in place, to use that stored DNA sample to arrange for appropriate genomic testing, with then onward follow-up through the ICC clinic. So this is what the new pathway looks like. And here we have the toolkit that I've already mentioned that has been used to develop the program itself, the pilot program, and will be used in terms of developing rollout into the broader NHS. So we've already discussed the coroner's officers training, the development of guidelines for referral, specialist pathology, and the retention of tissue consent form. There are also additional resources, family leaflets and coroner's officers training, for example, and then the signposting letter to the ICC clinic. And in addition to that, we now have testing criteria for genomic testing as well. So a comprehensive toolkit that can be shared across NHS England. So these are some examples of some of the materials that have been generated. So information has been co-produced with Cardiac Risk in the Young and the British Heart Foundation. And not in addition to that, we now have within the test directory, as Kate Downs has already described, we have clear test indications for how these stored DNA samples can be used from the deceased probands. So R138, for example, is the sudden unexplained death of survivors of a cardiac arrest. So that is a fully approved panel that gives access to comprehensive genomic testing to try and identify an underlying inherited cause for somebody who's deceased because of an inherited cardiac condition. So they are now, testing can now be routinely obtained via the test directory. And just to very, very briefly to finish off, over the approximately last year and a half, we can see that the number of cases going through the pathway, and this has now been updated to nearly 150. But as you can see, that results in a very large number, between 500 and 600 of at-risk relatives being identified. And approximately half of those are now within the Inherited Cardiac Condition Service being evaluated for their own particular risk. So the pathway in just the 7 pilot sites has now taken off very successfully. This is the evaluation that has been commissioned to look at this initial pilot program carried out by Bright Purpose. Next slide, please. But obviously what this leads on to is the vision for national adoption. So for every index case, living or deceased, where a cardiac genetic disease is the suspected cause of either an out-of-hospital cardiac arrest or sudden death, to be appropriately identified so that all living index cases, first degree and at-risk relatives, receive that appropriate and timely follow-up and genetic testing in a specialist ICC service. So it's being able to add in genetic testing that is key to this new pathway. Next slide, please. And the transition from pilot study to national service provision involves several steps. Firstly, the scale up from 7 pilot sites to include all the ICC clinics and coronial services in the next 12 months. We've secured funding from NHS-C and BHF to fund that particular process prior to NHS commissioning. And also we're now seeking to make the appointment of the additional ICC coordinators to allow that rollout to take place. Next slide, please. And we've already heard about Genotes, and I would encourage you to go to Genotes. You'll see that cardiology is now one of the identified specialties. Next slide, please. And within the specialty collections, you will also see that there are now G-notes provided for the appropriate indications for testing for the genomic tests that I've already discussed, such as sudden death in a child. So thank you very much indeed. We'll pick up questions during the question and answer, and in particular, big thank you to Joe Lowry, who has been coordinating the pilot site delivery in our region in Leicester. Thank you very much.
Hi everyone, my name is Aris Saoulidis and I'm a clinical pharmacy lead for East Genomics and a job share with Paul Selby, who is also a consultant pharmacist in Genomics. And today I'll be talking to you about how the pharmacy team in the East is working in collaboration with all the wonderful colleagues you have heard talk today, and with our counterparts in other genomic medicine service alliances across the country and NHS England to deliver on how we can best use genomic tests to inform the best use of medicines. And a couple of the projects I'll talk about today focus on rare disease, and some of them are also related to pharmacogenomics, which I'll mention on this slide what that means. So when we use medicines, the best use can be informed by the way that a patient's genetic variation is shown to influence the response to medicines. And there's quite a few different ways of how genomics can inform medicines use. There's genetic therapies where they can address the root cause of the problem by essentially fixing, for lack of a better word, what the problem is on the genetic level. There's now new targeted treatments that specifically are designed to address a problem caused by a specific genetic variant, or for example in cancer or rare disease such as cystic fibrosis. And pharmacogenomics is when we use genetic variation at patient level to influence how we can best dose a medicine, or what's the best choice of medicine when you have lots of different medicines to choose from. You can also use genomics to identify what existing drugs can be repurposed when evidence is there in genetic diseases that don't currently have other treatments available to them. And you can also use genetics to predict antimicrobial drug resistance and cancer resistance. This is not so relevant in rare disease, but it can be when you're treating infections associated with rare disease. And there's quite a few different things involved in implementing genomics around medicines specifically, and we are supported by NHS England's Genomics Informed Medicines Optimization Board nationally to identify a lot of the different aspects to implementation of genomics in medicines optimization. For example, you have to consider how you can train your pharmacy workforce or a workforce that prescribes medication. You have to be able to provide horizon scanning that predicts, you can see what's in the pipeline to be implemented in the short, medium, or future longer term. You also have to consider how the test's evidence is evaluated and how it associates to medicines that you're interested in specific patient pathways. That also relates to what research is going on in this space and how you can integrate it into existing clinical pathways that we heard about other colleagues talk about. Then you have to think about how this works in a digital space, how you can best make the best use of your digital tools to support this. And finally, how can you raise awareness in relation to also training people so that you can get them to learn more about this and how they can use it in their daily practice to make sure it's a routine use in an equitable way. So the first pharmacogenomic test I want to talk about that's related to rare disease as well is aminoglycoside-induced hearing loss. So aminoglycosides are a large class of antibiotics, such as gentamicin, tobramycin, neomycin, and they often present patients who receive those antibiotics for a given infection. They might actually present with ototoxicity, which means they can have hearing loss or other problems like vertigo or vestibular toxicity. And it's variable in terms of how soon or how often this hearing loss or deafness can present. And there's now a very big body of evidence that a lot of this ototoxicity can come from genetic factors. So some patients who have a specific genetic variant can be a lot more sensitive to this side effect and can even become deaf even after a single dose. So there's a genetic variant that exists in a mitochondrial gene. So mitochondria are small cells, small organelles in our cells, and they can sometimes carry a mutation or a variant in the mTRNR1 gene. And as mitochondria are always inherited from mothers, there's also implications that you might want to consider in terms of cascade testing, such as other colleagues have mentioned. So about 1 in 500 patients have a genetic variant that actually increases the risk of ototoxicity or deafness after you have those antibiotics. And this is now currently an established test in the Genomic Medicine Service and in the East. And the eligibility criteria for this test include a preemptive pharmacogenomic test, where if you know your patient has genetic disease or generally any kind of illness that will predispose them to an infection, then you're allowed to ask to test for this genetic variant to be able to inform the future use of antibiotics and help hopefully prevent deafness in about 1 in 500 of those patients. So a lot of common conditions, a lot of rare diseases that are the most common, I suppose, are cystic fibrosis, primary ciliary dyskinesia, and alpha-1 antitrypsin deficiency. These are just some examples. The eligibility criteria are not specifically confined to those, but the cystic fibrosis team in the East in general have been excellent in integrating this test in the routine pathway. So all patients who are diagnosed with cystic fibrosis at Cambridge, for example, they go through this test because these patients are very prone to infections, unfortunately. So patients who have were returned positive for this test, they don't have these antibiotics, they have something else instead. We're also considering the implications for expanding this project in the future to potentially identify mothers who might be known to give birth to a child with a specific illness that will predispose them to such infections, so we can preemptively test the mother so we know what the child's mutation or variant will be. And we got together with the pharmacists nationally to identify eligibility criteria for these conditions, because potentially we identified there's 100,000 patients that could potentially be tested nationally. At the moment, the awareness of this test is lower than it could be. And we're working hard to make sure that colleagues in relevant areas are aware that this test is available and how they can work together with the lab to identify patients eligible for testing. And I want to talk about 2 projects that we are just starting off in the East GMSA pharmacy team, and they're essentially 2 sides of the same coin in a way. So the first project I would like to talk about is a diagnostic and treatment odyssey, which will focus on the experience of patients and clinicians of that journey to get the diagnosis of rare disease and a precision treatment at the end of it. And you can see here there's a spaghetti type of journey for a lot of patients, which I think a lot of colleagues have mentioned already. I'll just go through it in a little bit of detail in a moment. So there was a big survey conducted this year by EuroRDIS, Rare Disease Europe organization, that essentially consolidated this some of the data, at least in the European populations, of how the diagnostic odyssey looks like. So a lot of people, what is a diagnostic odyssey? It's when you notice your first symptoms of a disease and you have a contact with a medical professional, for example, it can take years until you actually finally reach your accurate diagnosis at the end of this. And that can involve having lots of waiting times in the beginning until you see your first doctor. Then if you have a complicated condition that is not specifically obvious of what it is, or if it has symptoms that might be putting your condition in a differential diagnosis that the doctors first thought would be that they might have something more of a common disease, then the rare illnesses might be missed. And in some cases, this can go up to 3.5 years, even up to 4 years, until someone realizes actually they might not have a common disease that I thought was the case, if they actually have something like a rare disease. And that's where the GP, for example, refer the patient to a specialist or a center of a tertiary center that manages such patients. About 60% of patients have a potential misdiagnosis with physical diseases, and another 60% of them have a misdiagnosis with psychological symptoms. And about 40% of those patients in that survey were not referred to a center of expertise. And 25%, 1 in 4 patients had more than 8 consultations with healthcare professionals before a diagnosis was made. And you can see there's actually quite a variability, a heterogeneous approach to how long it takes for different types of different ages of patients to reach a final diagnosis. So the most vulnerable populations here are young adults, adolescents, and children. Next slide, please. And also women tend to receive a diagnosis later than men, which is a known health inequality in the system, unfortunately. Yeah, so, and the thing is that the diagnostic odyssey is a concept that's been explored in several research projects. There's a vast amount of literature out there. And when I was reading about it and learning more about it, I always thought as a pharmacist, okay, what happens to the treatment? In pharmacogenomics, we always talk about that one medicine does not fit all patients. And in precision medicine, we always say that you have to tailor the medicine to the patient's profile. You don't just give a medicine that seems to be, that maybe should work. And that made me think about something called the treatment odyssey. There's a knowledge gap recognized by NHR and the rest of the rare disease community that approaches to treatment can look like a trial and error until and after the genetic diagnosis has been made. And this can look like different treatments being given at different parts of this pathway, where you visit your primary care physician and they give you a medicine, then they refer you to another specialist who might diagnose you or may not diagnose you. And you have this vicious cycle of wrong or ineffective treatments. And this is really what we want to explore with this project. And we want to start by narrowing down the patient cohort that we want to explore in the first instance of this project. So there's about 7,000 rare inherited diseases, but only less than 700 of them have actual treatment options. So we want to start with those. Then we want to narrow it down to conditions that are not checked at birth and those that have overlapping symptoms with other common diseases or rare diseases. So they have to be conditions that are often missed or misdiagnosed. And we're going to start by pinning down to 5 conditions and interview about 100 patients with a confirmed diagnosis. So this is going to be a very much patient-centered, sorry, I haven't finished the end. This is going to be very much a patient-centered research. We have involved the East GMSA Patient Public Voice Panel and the medical teams, and we're setting up a priority setting partnership with patients, GPs, and geneticists. And also we're going to bring on board rare disease stakeholders from the East to identify what those 5 patient conditions will be and how we're going to conduct the detailed methodology of this project. So the plan in our immediate next period is to map those journeys for those 5 conditions and understand how patients present from the first symptoms to diagnosis to then treatment. We're going to associate all the data that we have, prescribing patterns, demographics, postcode characteristics, to the patient journeys. And we're going to evaluate all the treatments used at each step and why they were used, and also how patients access targeted treatments after the diagnosis has been made, and how they can be involved in new drugs or through clinical trials or drug repurposing. And the output of this will be thematic analysis, where we're going to provide those barriers and enablers to diagnostic and treatment odyssey in the East. And our hope for the longer term will be, I haven't put it in the slide in writing because it's not confirmed, but we want to create a pipeline locally by having staff that specifically do this work And we're going to refine the methodology to repeat this process in more rare diseases in the future. At the moment, we're only going to look at 5, but as I said, there's about 700 diseases that have a treatment option available. We're going to seek further research funding to expand on this and identify those key themes and details that we require to inform our practice, how we're going to inform our learning and workforce strategy that can support policy and commissioning changes nationally and locally, and generate those transferable lessons that we can apply in other areas. And next slide, please. And the other project that we're working on with Paul, led by Paul, is the other side of this coin, essentially after the diagnosis has been made. So we're working together with colleagues from the Southwest, GMSA, and the Genomics Informed Medicine Optimization group that I mentioned, to understand how genomic testing influences treatment in rare diseases. And that's going to support, this project will support enhancing the access to genetic testing that specifically unlocks precision medicines in several rare disease areas. So again, we're going to map the pathway to treatment, how patients access the test, and understand what the supporting resources are available, including the data, and how we can provide recommendations to improve this. So it's a similar slide to the first one here. So specifically around genomics-informed treatments, we want to understand how what the specific elements are in those specific pathways that inform how you can access a precision medicine, how gene therapies are unlocked for those patients, and how this relates to the specific genetic diagnosis. So the substratification levels of a different genetic diagnosis. And there's really about 4 outcomes that will come out from this. So we're going to use our learning to inform how we can map pathways in the future better, because these are very complex pathways. And it's going to inform the future rapid uptake of precision medicines as they come along. It's going to help deliver all those pathway components, so breaking down every step of the pathway, and learning how we can improve this for the next medicine that comes along. We're going to also learn how we can best raise awareness of precision medicines and the genetic testing required to unlock those precision medicines specifically. And also understand what are the specific factors that are required to improve education and learning resources for the different professionals involved in a specific pathway. At the moment, we're focusing on the pathways with patient-specific areas with innovative treatments, and we have thought about the exclusion criteria. And at the moment, for this project, we're excluding clinical trials and off-label medicines such as drug repurposing. So the first condition we are going to focus on is spinal muscular atrophy, which has a lot of innovative treatments like nusinersen and onasemnogene and abeparvovec, risdiplam, which covers a wide range of the different types of treatments I mentioned earlier, because it ranges from gene therapies to gene expression enhancers to simple drugs. And there's a lot of multiple treatments in the pathway. There are very few specific treatment centers that we can engage with and review how the patient journey looks like. And the commissioning for it is fairly straightforward. And once we understand this model, then we'll expand this to more treatments, for example, hemophilia in the future. There's a wide range of national, regional, and local data sets that we can identify, that we have identified and will interrogate. And once we have the methodology defined, again, we're going to apply this to the next rare disease area and the next rare disease area, and map all the data along this pathway, where we're going to develop educational resources and identify gaps and opportunities in the pathways. And that's it. I have another slide, I think. No, that's it. And just I want to thank everyone for listening. If you want to get more involved, especially in the rare disease work, please get in touch. We'll be very glad to hear from you.
Great. Thank you very much, Aris. Dick mentioned earlier that we work with a number of strategic partners. So I'm pleased to introduce 2 representatives, Joe Balfour, Managing Director, CamRare, Louise Fish, Chief Executive of Genetic Alliance, as part of the next session, which is a view from our partners, and they will share the current and future priorities at their respective organizations. Welcome, Louise. Welcome, Joe.
Hi, thank you very much for the invitation to speak today. Good morning, everyone.
I'll just quickly introduce myself. I'm Louise Fish. I'm Chief Executive at Genetic Alliance UK, and we are an alliance of over 200 rare charity and support groups for people with different rare and genetic conditions. And our priority is to work together to improve the lives of 3.5 million people across the UK who are affected by lifelong and complex genetic and rare conditions. And we run the Swan UK project, which is a community for people with syndromes without a name, which you may also be familiar with. Next slide, please. I feel like Chris Whitty now. What I thought I'd focus on first, I'm speaking first, I'm going to hand over to Joe from CamRare, is just to be really clear about what people want from genomic medicine services. And people do want access to genetic testing and to see whether it's possible to reach a diagnosis. Where it is, they're really keen to get a timely diagnosis. And I know this will be a kind of issue that's been discussed widely within genomic medicine services. There have been, as we know, long delays getting results from particularly whole genome sequencing back to people, and that timely diagnosis and whatever you can do to speed up is really important, particularly for families whose children are being tested. We all know that we want children in their early years to get off the best possible start, and getting a timely diagnosis is often seen by families as the way to unlock access to wider services, and that support after a diagnosis is given, particularly referrals to speech and language services, to physiotherapy. It's often not a particular treatment that people are looking for, but really to be able to access that wider support and advice. It may be learning disability nurses, but that support after a diagnosis is really important. And signposting to that support, both within the NHS. I've talked about speech and language therapy, physiotherapy, learning disability support, all of that's dietitians, all of that's really important. But so is signposting to charities and support groups outside the NHS. And it's often getting in touch with a particular charity or support group that will really help a family to get in touch with other people in the same situation. Even if there are only 5 families in the country affected by a particular condition, we have charities such as Unique who are able to join up and put people in touch with one another, either in the UK or overseas, with very rare diagnoses. And that signposting is really helpful, because what people want to understand is what the future holds for their child if they have a rare condition, and for the wider family, and particularly to be able to see what the future might hold, what the kind of lifetime development of a particular condition might be. Is it going to improve? Might it get worse? What will that long-term life course look like? And meeting other families who are ahead of you on that journey can be hugely helpful. And then I wanted to flag up, particularly from a Swan UK perspective, people are looking for ongoing support if a diagnosis is not possible. We know that around 4 out of 10 people don't get a diagnosis even after whole genome sequencing. It doesn't change the way that a particular condition is impacting on them. So they will still need support even if they don't have a diagnosis, with those wider services like speech and language therapy, like physiotherapy. And they may also need help to explain to wider services, particularly schools and colleges, what the impact of a particular condition is likely to be on them, and what support they will need to be able to live their life to the full. What support they'll need as an individual living with a condition, and what support they'll need for the wider family. So all of those things, as much as access to treatment, is what people want from genomic medicine services. I'm also asked, how can we put patients and families at the heart of all aspects of services? And I thought, again, this is a really useful place to be able to share some of that advice, because I know this is something that many of you will be grappling with. Often we find that when people are asking patients and families to get involved in services, they tend to ask for advice on really complicated things like service specifications or particular commission decisions. And sometimes families are able to help with that. But often the thing that patients and families can most help with in terms of thinking through how they can be at the heart of the service is some of the softer side of the work that you do. So ask for their help to talk to you about, is it easy to find the information they need to access your service? Often it's really hard to find out where the service for a particular condition is being delivered. So they can really help you understand where they'd look for that information and where they would want to find it. The tone of your communications, often it's written from the NHS's perspective, and it's very kind of practical and instructive. But actually, what families often want, particularly if they're at the start of their journey and they've just been diagnosed, is for the tone of your communications to be really warm and welcoming and reassuring that they've found the right place and that you're here to help. So families can give some fantastic feedback on the tone of your communications and whether it's the right kind of tone to encourage them to get in touch with the service. They can give great feedback on the timings and locations of your clinics and whether they're actually helpful to enable people to attend. I think we sometimes forget we schedule around the availability of clinicians, and actually what we're not thinking through is you know, if this is a clinic for a young family, how is this going to fit around their educational commitments and school timings? How is it going to fit around the need to travel if your service is very specialist and they're going to need to travel a long distance? We had a great example early this year of a lady who kept being put down as a do not attend for a local clinic that was, and she was being repeatedly invited for an invitation at 9 o'clock on a Wednesday morning, and she was a single mum with 3 kids who needed drop-offs at 3 different schools, and so there was no way she could ever get there till 9. By 9, she didn't speak English as her first language, so she was unable to get in touch and ask for a different time. She just kept hoping that the next letter would be for 10 o'clock or after, so that she could get to the clinic and come along for the service that was being offered. So I think that's really, really important, I think, just to think through and get feedback from people at the timing and locations of the appointments that you're offering. And then finally, is the content of your information simple and easy to understand for someone living with a genetic condition or a family member? And what about if English is not their first language? Often, again, the information is written for quite a high degree of education level. Many people working in the NHS have got degrees or second degrees or medical qualifications, and they tend to write in a way that would be appropriate for other people with those qualifications. But the most people in English, the average reading age is around the age of an 11-year-old child. So actually you need to write your information far more simply if it's going to be accessible for all families, particularly for people living with genetic conditions who may have some learning difficulties or learning disabilities, and making sure your services are accessible if English is not someone's first language. Again, writing as simply, as clearly as possible is really helpful to make sure your information is accessible to everybody, and patients and families can give fantastic feedback to you on whether that's the case. So I think these are some of the ways that are very simple. They're not about the complexities of the service and the clinical support you're offering, but they are ways to put patients and their families at the heart of the service. And then I think this is my final slide before I hand on to Jo. Yeah, what are kind of short and long-term solutions to really improve genomic services for patient benefits? Well, in the short term, I've talked through how it's you know, making it easier to access your services. In the medium term, I know that many of you are grappling with this and trying to look at how you can shorten the pathway, not to the whole genome sequencing, because we know that's relatively quick and easy now, but to improving the timeliness of how you're able to look at and interpret those results. And we know that that's really challenging within the context of NHS workforce shortages. We completely understand that this is really difficult because it's about having the right people with the right qualifications to look at those results and interpret them, and then to sit down and talk to family through those findings and with a genetic counsellor or a geneticist to ensure they really understand what the findings mean for them and their family, whether there's a diagnosis or not. But as I say, we know the challenges, but anything you can do and are doing to make that diagnosis more timely and get those results back to people quickly is just so appreciated. So thank you. And then in the longer term, we're really looking to people to develop clear plans and referral pathways, both for when a diagnosis has been made, referring on to both specialist services and those broader support services around things that we know matter most to people: learning disability nurses, nutrition and dietary support, physiotherapy, speech and language therapy. Those are the things that can make a massive difference to families, whether there's a clear diagnosis and a treatment or not. And similarly, thinking through what those referral pathways are and what the ongoing support will be for people who, despite having the very best that medical science can offer them at the moment, still don't have a diagnosis after going through those process, but still have exactly the same needs as they did before going through that diagnostic process. So yeah, I hope that's helpful. I'm going to hand over to Jo, and then I'm sure we're both happy to take any questions at the end. Jo.
Thank you, Louise. So I'm going to do a whistle-stop tour of who are CamRare, just to make a start. If you don't know us, we're very much about making rare diseases an everyday conversation. So let's move away from the rare. We know there are at least 3.5 million people in the UK affected. We do that in 4 key ways. So we're working very much locally and regionally with families affected by any rare disease or who are undiagnosed. And we do that through a regional support group called Unique Feet. I'll talk a little bit more about that later. We're also on a broader level, both locally, regionally, internationally and nationally, we're building multi-stakeholder networks, so getting people to work across sectors and collaboratively. We often facilitate that through our events. So on the left-hand side there, you can see some of the events that we organise on a regular basis. So we have our Rare Summits, which is a stakeholder conference once every 2 years. This November, we have our Rare Fest event, which is a much more hands-on, public-friendly, free event for everyone. I've mentioned our unique feet community. We host a companies forum in which we really bring pharma, biotech and life sciences industries representatives together to talk at a round table meeting several times a year. And we're developing a few research projects. So I'll go into that a little bit further on because they're things I would like you to know a bit more about. So that's us on the next slide, thanks. So I just want to emphasize some of the things that Louise has already touched on. For our families, diagnosis is definitely not the end. Diagnosis is for them the beginning of a much longer lifelong journey. And I just want to give an example really before I go into some of these ideas for signposting. This is not atypical. We have a big community of families in Cambridgeshire and the Eastern region. And what we see at the moment is that whilst whole genome sequencing is available on the NHS, it isn't always easy for them to access. And part of the problem there is the medical professionals working with families, connecting the dots and realizing when's the right time to signpost, when's the right time to move forward and to request genetic testing. We're still finding families are having a bit of a battle to get genetic testing. So that's the first point. The second is that once they get that testing, they're often waiting between a year and 2 years for results. And that's a long time to be left waiting. So I'm going to reiterate what Louise said earlier. Whatever we can do together to try and reduce that wait, reduce that anxiety period of waiting for information would be great. Once a diagnosis or even just test results are available, a letter arrives through the door. And I had a family just last week who received one of those letters. And it was a really, really difficult conversation to have with them. They were given a name of a disease, but they weren't given any information. They were given the name of a disease, but they weren't told about a community to support that disease. They were told that the disease was inherited from the father. Dad wasn't told how we might get support to deal with that guilt that he's now feeling about having passed that on to his child. They definitely weren't connected with any research. They weren't given information about where they might look to meet a community, find out more, begin to sort of get their heads around what this meant. And that worries me. It worries me a lot because what we had to do as a community is step in. So that person, fortunately, was already part of our unique feet group. And they were already very familiar with some of the stories that were going around in that support network. And they were able and confident to ask for help. So we then went on to do some of the stuff that I'm gonna share from this slide. And this is stuff that we can do. We can do the supporting and signposting, but the challenge for us is that we don't work with every family that's going to come your way. And we just support families who know we exist. So there's some backtracking to do here, and there's some help that you could give. So when you get these slides, you'll find that the links that I've mentioned on the right-hand side are actually live links. You can click on them to do a little bit more digging. But what families really need at that moment when they get that letter is they need information. It needs to be accessible. They need to be able to understand it in a language that works for them. Louise mentioned a reading age of 11. Just sort of understand what that means. The Guardian newspaper is about a reading age 11. The Mirror and a tabloid is about 8. So good, accessible, quality information links to websites. Those websites might be information, or they might be a community. They might be a charity that has good information about that particular disease. And in some cases, if there's not a charity, which isn't uncommon, perhaps a link to a research paper. So first of all, give them some information so that they can go away and not have to do the whole Dr. Google thing. The next thing that they really need is a community. So as Louise already mentioned, you know, having that local support is fabulous, and we support people with any rare condition, but also having that really disease specific support is important. You know, what is my disease going to look like in the future? Can I meet other people who are going through the same thing as me? So please do look to the right to some of these, you know, really fabulous, often umbrella organisations. So if you're in the Eastern region, you can signpost to Unique Feet to our organisation. More broadly, you can get in touch with Louise at Genetic Alliance UK or through their SWAN group if there isn't a diagnosis. There's Metabolic Support UK, there's Gene People. Gene People offer a really unique service where they have a genetic counsellor. So actually that's what we did with this family. We said, why don't you give Gene People a call whilst you're waiting for an appointment, and just run a few things by them. There's also Unique, and they've got some fabulous online resources. They deal primarily with rare chromosome disorders, and there's Rare Minds. Rare Minds is a fairly new organisation, but they're supporting with counselling and mental health support. So provide some information, make sure it's good. Signpost them to a community. It's really important to get that network. Then these people want to get involved in research. I find that our rare disease community are incredibly passionate and engaged with the idea of research. And I said I would mention something that I flagged up on the last slide, and that's our new rare disease research network. There's lots of these sorts of networks emerging at the moment, but what's different about this one is that we created it with 30 patient group representatives. So people with lived experience, either a disease themselves, a parent or a caregiver, or they were involved in an organisation. And through some NIHR funding, we have built a platform where patients are going to be able to share their own research ideas and their own research priorities. So please do, in the future, make people aware of this opportunity. Help them get involved in research, because we all know that 95% of rare diseases currently have no treatment. We can help with that if we can all work together. And just a final thing before we close. One thing that we have discovered over the last 2 or 3 years of working with our families and the wider community is that communication matters. Communication to them is everything. So imagine every time you go to the doctors, every time you go to the hospital, every time you visit teachers in school, you speak to a social worker, you speak to your allied health professionals, you're having to tell your story over and over again. This is not unusual for people living with a rare condition. It's also not fair. Healthcare professionals can't be expected to know about every rare disease. So what we're trying to do here is provide a way for families and young people and individuals with a rare condition anywhere in the world to have a tool which helps them communicate not just their medical condition, but also how they like to be cared for. So we, with our community, have developed over the last 2 years a rare patient passport. And at the moment, it's a very simple tool. You can actually see some photos of it there. We have one of our rare bears is showing off their passport on a lanyard. It is actually in the right-hand photo. You can see it's a 2-page document. It can be printed as such. It's fillable and it's owned by the patient. They complete it themselves, but ideally with your support. And then it can be folded and put in a lanyard to wear around the neck. So if you've got any families that would benefit from being able to have a communication tool that succinctly tells their story, please do scan the QR code there when you get the slides and signpost them to that. In addition to that, we're also partnering with patient groups and with healthcare settings. So at the moment, we've got about 60 patient groups, not just in the UK, but worldwide, who have said, we want to give this to our community. So we've added their logo to the passport, added their web link, and they are circulating it amongst their members. We've got 2 or 3 healthcare settings are also doing the same. So if you have a healthcare setting and you're thinking, okay, this would be a great way to support our community, then we can do likewise for you. We can work with you to run a pilot, to do a service evaluation, or to add your own logo and web link to a passport. So get in touch. I think that's it from me. So I would just say, look back to the slides. Please do take those slides when you get a hold of them. Look back to Louise's suggestions. Look back to the kind of signposting ideas that I've shared. Have a little delve into some of those links and find out about some of these great organisations. And please, please signpost.
Thanks very much, both. Fascinating. As you say, we will be circulating the slides so everyone can access those links. So thank you very much. Just to move us on, I want to introduce the patient story section. So we've heard a lot about the genomic medicine service and testing and education and training from the healthcare professional side of things. So I'm delighted to welcome 3 sets of patient stories. If I just advance my slides. The first is Loretta McInnes. So Loretta has a diagnosis of Fabry disease. She's got a great blog actually called My Fabry Disease, which you can check out. She's also on our patient and public voice panel. And a lot of people have talked about Diagnostic Odyssey, and I'm sure Loretta's going to want to pick that up in her presentation. We've also got, just to introduce everyone at the top, we've got Chris Hind, who has a diagnosis of Haemochromatosis, and Chris is the chair of our PPV group, our Patient and Public Voice panel. And then we have Joe and James Sandy, who will be in conversation with Dr. Kate Downs, who you heard from earlier. And Joe and James have 2 daughters, both born deaf. Their second daughter, Opal, went through a gene therapy trial at Adam Brooks Hospital and actually had hearing restored in one of her ears. And it's a fantastic story. So can't wait to hear from Joe and James in conversation with Kate. But without further ado, I'll hand over to Loretta to tell her Fabry disease story. Thanks, Loretta.
Thanks, Ian. Can we just move the slide on? So thank you. So as Ian said, my name's Loretta McInnes. I just wanted to talk to you a bit about my journey, a lot of which has resonated with some of the stuff that Lucy was talking about and Joe, etc. So yeah, very interesting presentation so far. So I just want to cover what is Fabry. I want to talk to you a bit about my journey, my odyssey, a diagnostic odyssey, and the future. Next slide, please, Ian. So what is Fabry? Well, Fabry is the world's second most common genetic metabolic storage disorder. And it was discovered in 1898, or first identified in 1898 by 2 men who were both working independently, a guy called Johannes Fabry, who was a dermatologist, and a surgeon called William Anderson. And its full name is actually Anderson Fabry disease. And it was identified as a lysosomal storage disorder in 1952. So that's a bit of history. In terms of what it actually is, it's a variation on the GLA gene. And it results in a reduced amount of enzyme called alpha-galactosidase, alpha-Gal-A. And this alpha-Gal-A is needed to actually break down a fat, a glycolipid, which is GB3 or GL3, it's also called. And that causes the problem. So without the enzyme, this GB3, this glycolipid, builds up in various organs of the body. And that can be the heart, could be the kidney, can be the brain, and it varies person to person, and even family members who have got the same mutation can have variable issues with the build-up within the body.
and that causes the problems basically. So luckily for Fabry sufferers, there are treatments available. So there are enzyme replacement treatments. There are 3 currently available: Fabrazyme, Replagal and Elfabrio. And there's also an oral chaperone treatment, migalastat. And we're quite lucky in the Fabry community in that there is a lot of research going on, including into gene therapies. So estimates really vary for the amount of people that are thought to have Fabry disease. So some estimates I've seen are 1 in 115,000, others, and the most common one that I've seen is 1 in 40,000 people. But I've seen one recently that was 1 in 1,250 people. And that was based on newborn screening of males in Taiwan. And they've around a cardiac variant of Fabry disease. So it potentially is heavily underdiagnosed. And it's X-linked, it's an X-linked disorder. So a man with Fabry will pass the disorder on to his daughters, and a woman with Fabry will have a 50-50 chance of passing the condition on to their sons or daughters. And 1 to 2% of people with Fabry are found to be de novo. I'm one of those 1 to 2%. It wasn't in my family before, so it would have been no good looking at my family history to try and diagnose me, because nobody had it before I actually got the mutation. So just to talk a little bit about my journey. It was a long journey to diagnosis. So I started off having neuropathic pains when I was a kid. I remember screaming in agony when I was very young and being taken to the doctors, marched off to the GP, who said, "Oh, you've got growing pains." So didn't really think anything of it, just carried on. I started getting heart problems in my 20s, which were increasingly problematic, increasingly abnormal ECGs, left ventricular hypertrophy, and they were all dismissed as just one of those things. I was told, you've got no risk factors, and that's the big thing. I was youngish, young. I was seemingly quite fit. There was no family history of any issues, so it was, you had no risk factors, just one of those things, go away and get on with your life. And it was hard trying to deal with that. There was also corneal whorls, going back to kind of eye issues. Now, I had contact lenses from when I was 16, so I would have had a lot of slit lamp examinations, all of which would have been able to see these whorls in my eyes, but nobody actually mentioned it. And the first optician that actually mentioned this to me was post-diagnosis, and I was able to explain to them that it was caused by the Fabry. And my kids' health issues. So 2 of my 3 children have Fabry, and they had also had the neuropathic pains when they were very young. Again, dismissed as growing pains. Really frequent viruses, kidney issues, digestive problems, really debilitating stuff that resulted in a lot of missed education, a lot of missed issues with sporting activities, etc. But despite seeing numerous doctors, paediatricians, we were just dismissed. They were all dismissed as childhood illnesses. Next slide, please. But actually, these were every single issue that each of us had were all red flags for Fabry. But all these red flags were missed because we were deemed to have no risk factors. Now, if I'd been told once, I'd been told 100 times, you've got no risk factors, you're fine. And it's because every doctor we saw, and they were all talented physicians, but every doctor we saw did this. They looked at the particular part of the elephant that was presented to them. And that's what caused the problem. Nobody took any time to stand back and join those dots. And that was until I had a collapse in Manchester. And I was taken to hospital, and it was quite severe. I had a really bad arrhythmia, and I remember the paramedic standing over me with the defibrillator, you know, by the side, and it was quite a terrifying experience. Luckily, the defibrillator wasn't needed, thank goodness. But in A&E, I saw a cardiologist, a cardiac registrar, who said, "I think my consultant would like to see you because he's very interested on unusual cardiac issues." And this was the changing point for me, because in those 10, 11 days I was in hospital, that consultant came and did what I call, he practiced the Green Cross Code. But for those old enough to remember the Green Cross Code, man, he stopped, he looked, and he listened. And he came to my bedside and he took a detailed history. He went way back when, and he kept coming back and asking more questions. And he went away and he came back to me and he said, I think you've got something genetic going on. He said, it could be a genetic cardiomyopathy. Would you be willing to undergo genetic testing? And I just said, well, yeah, I'll do anything, because I need to know what's going on. You know, I'm desperate for an answer, even though I didn't think it was anything genetic, because nobody else in my family had it. And I had always assumed that genetic meant hereditary. So I must have got it from somebody. But nobody else would have, my parents and my grandparents, nobody had had cardiac issues in the past. So I didn't think it was genetic, but I was willing to undergo the genetic testing. So I met, after I was discharged, I actually met with my cardiology consultant and the genetic counsellor together. And they both went through the process with me, and the pros and the cons. And I had my blood test. And then I didn't hear anything for about 6 months. And to be perfectly honest, I wasn't worried, because I didn't think it was anything genetic. So when I got a phone call 6 months later from the genetic counsellor to say, you've got Fabry disease, I was quite taken aback. I was quite shocked. And then we had another meeting. We had a sit down, myself and my husband had another meeting with the genetic counsellor to talk about the family implications and to look at the family tree. And that's when the guilt started to kick in. It was and the worry, because the implications were that the children could have it and other family members could have it. So first of all, we had a meeting with the children, a subsequent meeting with the children, and they agreed, yes, they all wanted to have the tests. So they had their tests, and the timescale to get those results back were quite short, because they were looking for a specific anomaly. And they found that anomaly in 2 of my 3 children. They were subsequently diagnosed with Fabry, and we were all referred to a specialist team. Now, this was good because there was a specialist team to be referred with. We had a diagnosis. There was a problem, though, because my kids were transferred as teenagers into adult services. And particularly for my youngest, who was 14 going on to 15 at the time, this caused real issues, because the adult services did not know how to deal with children. And he's been left with long-standing issues because of that. So in terms of the future, well, my wish list for the future is really based on my experience. Continued research, including more patient-led research. So Joe's already talked about some of the research that's going on with the Rare Disease Research Network development. I've been part of helping to develop that, a very small part. But it's so important from my perspective that research is not just academic and clinical and pharmacological, but it is also patient-led, because sometimes the research that we as individual patients need is not necessarily what a clinician or an academic researcher would deem as the most important thing. So patient-led research, really important. Curious clinicians, such a big thing. If I had not met that registrar who put me in touch with his curious consultant, who took that time to stop, look and listen, I would probably still not be diagnosed, and my kids would still not be diagnosed, and we would not be getting the treatment for our progressive disease. So curiosity is absolutely vital. Stand back, take a history and join the dots, because then you will see that it isn't just that individual little issue that's presented to you. It's the bigger picture that's important. And the other thing I will say is that this issue of going into primary care with a notice that says 1 patient, 1 problem is a real problem with diagnosis, and it reduces the likelihood of things like my Fabry disease being picked up. The expansion of newborn screening. So Fabry disease, although it has a treatment, is not part of newborn screening, and I'm not really quite sure why, but I do believe it is underdiagnosed, as I'm sure many conditions are. there is treatment available and there is family support available. So why aren't we seeing it as part of newborn screening? Being rare can be really lonely, even when there are support networks available. But in order to access those support networks, you need to know what you have. And so really important that where possible, it can be genetic issues can be identified as soon as possible. And if there is newborn screening potential, then I really do believe we should be looking into that. And finally, really the next two are linked. The expansion of paediatric care to 18-year-olds and extra support for young people until 25. Teenage years and young adulthood is so vital. And you undergo so many changes and you need support just to go through that normally. But when you throw in the medicalisation of a rare disease diagnosis, you really need to have that extra support network and those wraparound services. And at the moment, they just aren't there. So that is something that we really need to look into. And finally, mental health support. It should be an intrinsic part of your diagnosis package, of your care package. It should not be an add-on. Because when you ask somebody, do you need mental health support? 9 times out of 10, they're going to say no, because they're embarrassed by it, because there's still a huge stigma, or they feel they have to remain strong. As I did, I felt as though I needed to remain strong for my kids. So it should be intrinsic. You should just be given it as the norm, and it should not be an add-on. So I just want to say thank you for the opportunity to tell you my story. And there are some ways to get in contact with me. I'm also a trustee of CamRare, so see you hopefully at RareFest in November this year. So thank you very much.
Thank you, Ian, and good afternoon, everybody. Thanks for the introduction, Ian. So moving straight on to the next slide, please, Ian. I'm going to really sort of talk about my journey with haemochromatosis over the last 5 years since I was diagnosed. So 5 years ago, I hadn't got a clue what haemochromatosis was, never heard of it, didn't know anybody that had it, and just thought, okay, what's it all about? So it does have some nasty side effects if not diagnosed early on. So in my case, I have a faulty gene, which is known as C282Y homozygous, which means that both my parents were carriers, as it's a recessive gene. So it skips a generation. So with haemochromatosis, the iron from your diet has to go somewhere. And if your body can't get rid of it naturally, it gets stored in all sorts of places where it shouldn't be, and can lead to complications later on if not diagnosed. So it's also known as the Celtic curse or iron overload. And as you can see from this map, it's very prevalent in Ireland. And interestingly, I have Irish grandparents on both sides of my family. So no doubt that has something to do with why I have the condition. So I was diagnosed at age 59 with no known symptoms at the time, or so I thought. As you can see, it's quite rare, but I'm not sure how you define a rare disease. But in Ireland, Northern Ireland particularly, 1 in 10 people have haemochromatosis, which is extremely high. But in England, it's about 1 in 150. To put that into context, I think there are about 40 to 50 patients currently receiving treatment at the Norfolk and Norwich Hospital out of a population of roughly 1 million in Norfolk. So it's still fairly rare. And obviously, as I say, if it's not picked up early enough, it can lead to very nasty complications. So once I was actually diagnosed, I had haemochromatosis. I was tested for everything, given a full NHS MOT, which included colonoscopy, gastroscopy, ECGs, ultrasounds, and other blood tests for various functions. I saw a haematologist within a month and started my treatments literally a week later. I was also referred to a liver consultant who discovered that I did indeed have some damage to my liver, which is obviously where all the iron had been stored for the last sort of 40 or 50 years. And I've got sort of mild cirrhosis of the liver, which has to be looked at every 6 months with an ultrasound. But fortunately, it has got slightly better and doesn't require any direct treatment. as you can see, it can lead to much higher risk of liver cancer in men. And interestingly, my grandfather died of liver cancer age 65 and obviously was undiagnosed with haemochromatosis. So many GPs will say they've only seen 1 or 2 cases of haemochromatosis in their career. Fortunately, my GP spotted it early on. I had a blood test for a persistent chest infection, and when the results came back, he saw that my iron levels were through the roof. So I had further testing for haemochromatosis, which he had obviously identified as the probable cause, and discovered that my ferritin levels were 50 times higher than they should have been. So instead of being the normal range of 50 to 300 micrograms per litre, mine were 4,500, so considerably higher than they should have been. But I had no idea that this was the case, and as I didn't really have any symptoms and wasn't aware of it. So as with all genetic or inherited conditions, it's important to get other family members tested. So both my sisters and all my first cousins were tested. One of my sisters has got it, and 2 of my cousins have got it. Interesting, my sister had a lot of trouble getting the right test. She lives in London, and her experience was not great. So the first 2 times the GP tested for the wrong thing, and the 3rd time when they did get the right test done, she didn't interpret the results correctly and was told that she didn't have haemochromatosis, whereas in fact she did. And it took another GP to correct that. So obviously with testing, it's important that it is done promptly and interpreted correctly. So once diagnosed, my treatment was basically to give a pint of blood every week for just over a year to reduce the iron levels in my blood. As you can see here, I was quite relaxed, getting fed warm drinks and biscuits by the nice venesection nurses every week. It's interesting that all you clever people out there probably know this, but the average human body has about 10 pints of blood, and it takes 48 hours to replenish that lost pint of blood, which I think is pretty amazing. Unfortunately, all my blood had to be thrown away as it couldn't be donated because of the high iron levels. And I'm now in what is called maintenance. So I have a blood test every 3 to 6 months to check my levels, which fortunately have been very good for the last couple of years. I haven't had to give any blood for a year. I have a liver ultrasound every 6 months to check that's all okay. Unfortunately, it's not bad, and I've got a liver scan this weekend actually. The Haemochromatosis UK, which is a charity, also recommends good dietary advice. So things like red meat and oily fish are to be avoided, and obviously reduced alcohol consumption. So fortunately, I don't like oily fish, and I have cut down my alcohol consumption. So in summary, I spent a lot of time in the hospital over 12 months in that initial diagnosis period, and I at that point decided I could probably do something to help the NHS. So I became more involved in my local hospital. I'm a public governor. I've also worked on the digital transformation committee as we're about to embark on a new electronic patient record system. And I've also been chair of the Patient and Public Voice for East GMSA for the last 2 years. So you could say if it wasn't for haemochromatosis, I might not have been involved in these aspects of the NHS. So in summary, living with genetic haemochromatosis is not too bad for me. Once the initial diagnosis was made, I had the bloodletting every week, and thanks to my sort of team of haematologists and hepatologists, and of course my GP, I've been okay for the last 5 years. And I should just say that there's a wealth of information on the Haemochromatosis UK website. It is a charity that does offer very good support. So that's pretty much it from me. So I'll hand back to Ian.
Good afternoon, everybody. Thank you so much, Joe and James, for joining us. We are going to spend a few minutes just talking through, I guess, Opal's story, and your family's story, really. So as Ian's mentioned before, Joe and James have 2 daughters, and both of those were diagnosed as deaf. And today we're going to have a bit of a talk about how a genetic diagnosis helped Opal and led to her receiving a pioneering gene therapy. So if you don't mind, Joe and James, I'm just going to ask a few questions, and then hopefully we can kind of talk through your family story together. So can you tell us, first of all, about Opal and how you discovered that she had some hearing problems?
Yes, so our eldest daughter is 5, and we found out that Nora was deaf when she was about 9 months old, when she wasn't responding to her name, and found out that Nora has a type of deafness called auditory neuropathy, which is a rarer form of deafness, isn't picked up in the newborn hearing screening. And then because we'd got that diagnosis of ANSD with Nora, we knew that any subsequent children that we had would be entitled to additional hearing tests beyond that initial screening at birth. So Opal was born in October 2022 and had her additional hearing test when she was 4 days old. So we were told then at 4 days that she had the same type of hearing loss. At the time, we didn't know that it would be the same genetic cause, although it was likely to be. But at 4 days old, we knew it was auditory neuropathy with Opal. Yeah.
And so then you discussed genetic testing, I guess, and had to decide whether or not. So can you tell us whether or not you got the same, you just tested Opal for the same genetic variant as her sister, or did you do a full gene screen panel on Opal?
So Nora had the full gene screening, okay, and that was COVID, and that took an exceptionally long time for the results to come back to us, by which point we were pregnant again. So with Opal, they just did the specific panels. So both the girls have a variation in the OTOF gene, which codes for a protein called otoferlin and prevents the cochlea talking to the auditory nerve. So everything else is anatomically normal. It's just this sort of synapse that doesn't have the correct protein to function properly. So Opal's genetic results came back relatively quickly. We're talking weeks, certainly not 18 months that we were talking with Nora.
So with Nora, I guess, I mean, that 18 months we've heard today from Loretta and others around that diagnostic odyssey. Now, 18 months, I think, to some of those patients who have been waiting for genetic diagnosis for years, it sounds quite quick. But I guess for you guys who had, a child, how's that wait affect you? And I guess Nora was being treated and you were considering cochlear implants, but at the same time, you really wanted to know the reason why she had that deafness.
We wanted to know the reason. So with our experience, the genetic element was very much sort of an addition. Like, our main focus was, we found out Nora was deaf. There were no gene therapy trials open for her type of deafness at the time. So the main option for us was 2 cochlear implants. So when Nora's genetic results came back, other than us being able to explain to Nora why she is deaf at an appropriate time, that was why we really wanted to find out from a knowledge point of view. But ultimately, it didn't change Nora's treatment path or indeed any outcomes. And then I suppose we just agreed to it for Opal to make sure it was the same. For again, the trial wasn't open when we had Opal genetic testing done. So again, it was just from a knowledge point of view. So the wait for Nora was almost irrelevant. We knew we'd get the genetic answer at some point if it was a genetic cause, but by the time we'd got that back, she was well away with implants and having speech and language therapy and making sort of progress that way. So we never really realized what a big deal this genetic testing would mean until we heard about the trial.
Yeah, so can you tell us about that? How did you find out about the trial?
So we were actually on holiday in Centre Parks when we received, well, you received a phone call from the lead surgeon at the John Radcliffe in Oxford, who had overseen our eldest Nora's sort of the procedure. He got in contact with you to basically say that he had a meeting with
some colleagues from Cambridge, some other ENT specialists, and he was aware that this trial was opening at Addenbrooke's. At this point, we knew Opal had the variation in the gene that they were offering gene therapy for, and he very much explained that it was a very new trial. Only Addenbrooke's, don't even think at the time, Gosh were licensed for it, but there was a centre in Spain and a centre in Cambridge, and nobody else had come forward. But would you like to consider Opal for this trial? Was sort of how we found out about it.
So it sounds like Opal was in that window where she could definitely benefit, well, potentially benefit from that. And she had the genetic testing results. And you guys were at Centre Park. So how quickly did that conversation move on? When did you decide to go ahead with them, with the gene therapy trial with with Opal?
So we got the phone call in Centre Parks in May last year, so about 14 months ago, and then her first appointment in Cambridge, where they had to redo all the genetic tests just for the trial protocol.
Okay.
That was late June. So she was officially enrolled on the trial in late June, but there were various sort of abnormal blood markers due to children starting nursery and having infections all the time. So she actually had the procedure in which she also had a cochlear implant on the other side. That was early September last year, so 10 months ago.
Wow.
So yeah.
It was about a month between us finding out about the trial to us enrolling her in it. Yeah.
So how did you discuss this? How did you feel about making that decision on behalf of Opal at the time? I mean, that seems like a really big thing.
But first thoughts that goes through your mind is obviously this is a brand new trial. She'll be the first person on it, so there's no previous data, no previous evidence of any
Adverse
complications that might come out of it. So that alone was our biggest concern. If we go through with this, yes, it could be great, but it also, what happens if sort of scenario goes through your mind. And we were provided with a lot of information from the trial team in Cambridge, which we spent a while sort of reading through, trying to get as much information as we could on board before sort of coming to a decision. But it is very much a decision based on what could happen with her in the future. We wanted to give her the best sort of possible outcome with dealing with safety aspects of life. So hearing fire alarms, hearing cars out on busy roads. And if she was able to hear those without any additional sort of cochlear implant or anything, then that was the route we were willing to go down.
Yeah, I think at the time when this phrase gene therapy was mentioned, I mean, neither of us had any experience of that at all. We spoke, as James said, to various medical professionals at Addenbrooke's, and the fact that the drug was being administered to a very small part of Opal's body meant that the risk to any other parts of her body was extremely small. We also happen to have some friends whose family work in genetics and gene therapy to do with sight loss and blindness. So we had some conversations with them, and the fact that if a trial gets to her sort of human rollout, then it's deemed very safe. And we also had the sort of fallback, if you like, that our eldest daughter Nora, she has 2 cochlear implants, and she very often when she's tired only wears one of them. So even if this hadn't worked and Opal were to remain deaf in that ear that was treated, we knew that the likely outcome of her with one implant would have been sufficient enough to enable her to have access to speech and sound. So we did have a bit of a safety blanket, having lots of cochlear implant experience and knowing that that was happening on one side anyway.
Yeah, wow, so much to consider. So do you want to tell our audience what gene therapy is for this condition, or shall I try and do it?
Yeah, you go for it.
Well, I think what's happened is, as Joe was saying, is that they use a adenovirus that's been modified to infect the cells of the cochlea to then express the gene that's missing. And so basically Opal now expresses the gene, sorry, I've forgotten what the gene is. It's the OTOF gene. She now expresses that gene within a cochlea due to this this therapy. So yeah, I mean that's fantastic. And so what are the results of the gene therapy? Has it worked?
Yes,
very much so.
Yeah, it has worked. It didn't work instantly. So we first noticed her turn to really loud intermittent sounds like clapping about 3 weeks after, which was mega. And then it sort of stayed at that really loud sort of banging level until about week 24, so about 5-6 months afterwards, where we noticed she was turning more to voice, name. It's been quite difficult to test because she obviously has her implant on the other side, but she needs to have on as much as possible so that her brain gets used to like processing electrical stimulation from the implant and then like acoustic stimulation through her normal gene therapy treated ear. So yeah, the latest results say she's got near normal hearing in her right side at the low and mid frequencies, and then sort of a slight loss in the very high pitch frequencies, which is just, as James was saying, from a safety aspect and shouting after kids that run off is just a massive life benefit for her.
Wow, these are just amazing results. And so I guess I've got two real questions. So what do you think you'd advise patients who were in a similar position to you were last, well, I guess when you were trying to decide whether or not to have this gene therapy? What would you say to those?
I say educate yourselves, inform yourselves. Like, this is very much just one option for a very few members of the deaf community. Go and find out some more information about it. Speak to people who have had gene therapy in other areas. But for us, it's been hugely positive. Yeah, it's been fantastic, hasn't it?
Yeah.
Wow. And how's Opal doing now? And how's Nora doing now as well?
They're both great. Yeah, they're very loud, chatty girls, the two of them. They love each other's company. They love sort of dancing to music and making as much noise as they possibly can.
I think Nora, so Nora will ask quite often why Opal only has one special ear as opposed to two, and we've saw the doctors know so much information about you, Nora, that they were able to make a new medicine for your sister, so that's why she only has one implant. And then Nora knows that on the other side Opal can hear unaided. So yeah, life is loud and life is chaotic, but they have a really, really special bond. Ultimately, without Nora, we don't think Opal would have been enrolled on this trial, because the panel testing and the fact they'd have had to test her whole genetic sequence would have probably meant that by the time the genetic results came back, the trial, Opal would have already had her implants put in, probably.
Yeah, particularly with having children who are born deaf. And identifying that they're deaf at an early stage. I'd say almost, possibly the wrong term to use, but the pressure is on giving them access to sound as early as possible to aid their development in speech and language. So with the possible delay in having the genetic testing come back, we could well have already gone down the cochlear implant route.
Absolutely.
Before finding out that this trial was even possible to be enrolled in. Yeah.
Wow, and we're hearing similar stories from other gene therapies where, you know, we really need to be able to identify those children as early as possible and treat them. And as you've had with Nora, you know, often it's these families who have an older sibling that are being identified first. And yeah, we could spend all day talking about how newborn screening can help better. But thank you so much for joining us today. It's been really great to talk to you and to hear about Opal's story and your family story and your noisy family that now exists. So that's really good. Thank you so much for joining us, Jo and James.
Thank you for having us. Thank you.
We hope you found the session enlightening and engaging. We value your feedback. I think Ian's put in the chat, and are these links for feedback as well, Ian?
The large pink QR code is the feedback. I have dropped it in the chat as well, and I'll do so again. Brilliant.
So the large pink one is for feedback. Would definitely we value your feedback. Would love to hear your thoughts on the event and help us iterate and improve. And a big thank you to the GMSA team for coordinating and curating the agendas for these sessions. We've got our final showcase event tomorrow, which is the prenatal and peds. Gemma has already teased some elements that will be covered tomorrow, so please do join and or forward to relevant colleagues who perhaps might find these sessions useful. Thank you very much all, and hope you have a good afternoon.